to this esteemed gathering of cardiology experts, researchers, and practitioners. Today, we come together to share knowledge, exchange ideas, and explore the latest advancements in the field of cardiology. This conclave promises to be an exciting platform for us to learn from each other, create network, and get inspired by the innovative work being done in our community. Over the next few hours, we will delve into the latest developments, debates, and breakthroughs in the cardiovascular medicine. I would like to extend a warm welcome to our distinguished speakers, panelists, and moderators who have graciously agreed to share their expertise with us. Your contribution will undoubtedly enrich our understanding and spark magnificent discussions. To our delegates, I welcome you to this celebration of cardiology excellence. Your participation and engagement will make this event truly unforgettable. Let us come together, share our experiences, and learn from each other. Let us make the most of this opportunity to update our knowledge, foster collaborations, and ultimately improve patient outcomes. Thank you, and I wish you all a productive and enjoyable time at the conclave. Now, I request Dr. Anamika to take over and begin the proceedings of this meet.
Thank you, sir, for that warm welcome. So, without wasting more time, we will like to go ahead with today's program. So, this is the summary, how we'll proceed. So, our first speaker is Dr. Rajiv Bhagwat. Before that, I would like to invite on stage Dr. Ravindra Deshpande, sir, our president, and who has been very instrumental in the formation of this Association of Physicians of Palghar district. Sir, please come. Our moderator for this session, Dr. Prashil Patil, sir. Sir has done his MD medicine from Kolhapur, and he was an ex-consultant at PD Hinduja Hospital, Mahim. Worked with the cardiologist Dr. J.J. Dalal, sir, and had been actively involved with Dr. V.R. Joshi, sir, and has published multiple articles with him. At present, he is a consultant physician at Cardinal Gracious Hospital and runs his own home hospital at Vasai. So I would like you to come here and introduce our speaker, Dr. Rajiv Bhagwat, sir.
Good morning, friends. Today we are here for the special cardiology knowledge to share with our friends, cardiologists around. I won't take much time and I'll directly go to our topic. The first topic and the job given to me to introduce Dr. Rajiv Bhagwat. I think everybody knows about him. He has done his MD medicine and followed by DNB cardiology. He is attached to the various tertiary level hospitals in Bombay, including Bridge Candy, Lilavati, Nanavati. But the contribution to raise the cardiac cath lab in Shrushusha Hospital, he has done single-handedly and taken a lead and established that center of his single-handedly in 2012. Part apart the angioplasty, he is also expertise into the balloon wall valvoplasties as well as the peripheral vascular intervention. He has been having experience for more than 3 decades and done more than 10,000 plus angioplasty. He now established with a bifurcation club in India for education. This is the unique where the new upcoming cardiologists have been given the knowledge of the complex things which are to be followed, and he is doing it his own with his trust, and that's doing very good. And he's been awarded various even awards for the same work he is doing for the same. He has performed the decay crush technique, acute myocardial infarction, which cases are being reported worldwide and has the recognition. The first cyber soluble stent has been also been practiced by him, and the first deploying BVS for the left man also he has done it. So I'll call upon Dr. Rajiv Bhagwat to take over the session.
Ask somebody to have this. Okay. Yeah. Slideshow. Yeah. Thank you, friends, for having me here, and Prashil, and Lord Deshpande, Vineet, and friends. I would like to just give a brief thing about the Bifurcation Club. So this we established in 2016, and the basic purpose was to share the knowledge that we would do in those days with fellow cardiologists. And now it has also become sort of a course for budding cardiologists to come and learn the complex art of bifurcation angioplasty. This is the 10th year. And this year we had the privilege of establishing an award on Dr. Gandhi's name. M.J. Gandhi's name. M.J. Gandhi was my boss. And a lot of people, I think, in the audience would know who Dr. M.J. Gandhi was. He is one of India's pioneering cardiologists who was respected all over the country and established the first coronary care unit in the country in Sion Hospital. So we gave an award this year to Dr. Yves Louard. Dr. Louard is one of the premier proponents of bifurcation angioplasty in the world. He's a French cardiologist. So we had the satisfaction of having him here this time. Anyway, without wasting time, let us go ahead. So I would like to share a few slides on complex angioplasty as an alternative to bypass surgery. So we all know the evolution of CABG. In this chart or the pictorial, the most important one is Dr. René Faularo. In 1968, he is an Argentine surgeon who performed the first bypass surgery. And he had a very unfortunate end. If you read history, he shot himself in the chest at the age of 77. He ran an organization which promoted social as well as educational activities. He ran into debt. He presented a letter to the government of Argentina. They didn't help him, and he shot himself. A pioneering surgeon. And ever since then, and ever since angioplasty has come, there has been a debate. The last updated guidelines on bypass surgery have been in 2005. And this is the evolution of PCI, the first angiography, and the first peripheral angioplasty was done by Charles Theodore Daughter. He was an American radiologist, and his fellow Melvin Judkins did the first transfemoral angiography, and that is why we have catheters named on Judkins catheters. And then we all know that Dr. Grunzig, Andreas Grunzig, did the first angioplasty in 1977. Grunzig also had a very unfortunate end. He started flying planes, and the plane crashed, and he and his wife were killed in couple of years later, and he was just 39. So unfortunate end. And ever since angioplasty has come, I would say cardiologists who were almost like physicians and GPs in the eyes of the surgeons, angioplasty has given a respectable platform to cardiologists. And today we are competing with surgeons, especially for complex PCI, because the technology has changed and the results have changed. So this is the ongoing war between CVG and angioplasty, various trials, and this is an era before the drug-eluting stents where we had only bare metal stents. And then yes, bare metal stents definitely were at disadvantage compared to bypass surgery in complex PCI, in diabetic patients, kidney failure patients, and so on. And drug-eluting stents have definitely changed the whole scenario. And now when we have almost say third generation drug-eluting stents, they are even better. And this was a trial called Syntax. If those who are keen to understand the complexities of multivessel angioplasty, Syntax trial was a guideline, and to tell you whether this patient will undergo surgery or angioplasty. So the very simple method. Anybody who had a score below 20, those patients were subject to angioplasty or could undergo angioplasty, and those patients who had a score of more than 30 would possibly be sent for bypass surgery. So basically the syntax trial scoring depended on the site of the lesion, the complexity of the lesion, the length of the lesion, calcifications, and so on. So this trial had, now it has run out of time. It is, I definitely don't use it as a guideline anymore. I possibly use it for a year or so. And the current practice, because the concept has changed, the techniques have changed, people have become more experts, expertise has changed. And the biggest criticism of this trial was done in the first generation stents, Taxus and Cypher. The Taxus and Cypher stents actually should not have come to the market because the polymer on those stents was so inflammatory that there are a lot of sudden deaths reported in the US and Europe. And when those sudden deaths were analyzed by post-mortem, their stents were found to be uncovered even after a year. So a lot of cardiologists in the US and Europe stopped antiplatelet therapy or DAPT therapy at 1 year, and they found that these stents thrombosed. So the culprit was the polymer. The polymer was the culprit, and that is why they say now these stents should possibly have not come to the market. So the syntax trial was done with the first generation stents. So now possibly there is a need to have another trial with the newer generation stents head on and then compare CABG and angioplasty. We also have better techniques. We have IVUS, OCT, FFR there to guide us in an intervention. We have better pharmacotherapy available today. So as far as the latest goes, aspirin possibly in a few years will be history. There are a lot of centers in Europe which don't use aspirin post-PTCA. It is just plain simple clopidogrel or prasugrel. Aspirin is, and I also in my patients in low risk situation, I stop aspirin at the end of one month. In some patients where the risk is higher and the complexity is more, maybe maximum is 3 months. I don't give DAPT beyond 3 months. So these are a few slides on data. So if you have the CR and IR, CR is complete revasc, IR is incomplete revasc. So there is a small comparison where the major adverse cardiac event was almost similar in the angioplasty and in the revasc groups. In both complete invasc and major adverse coronary and cerebral events were also practically similar. So there are situations where we don't revascularize completely. So the situations are when you have small vessels or you have a jailed side branch and you have a non-culprit artery. If you do function guided angioplasty like FFR, you see that the FFR is possibly not indicative of a procedure. The FFR is below 0.8 is the only guideline where you do any FFR more than 0.8, we possibly can defer an intervention. So there are situations where the revascularization is not complete, and they also do well primarily because we understand the disease better. We have very powerful medical therapy. The power of medical therapy cannot be underestimated. I have seen patients with lesions remaining the same or possibly regressing with high dose statins, ACE inhibitors, antiplatelet therapy. So power of medical therapy cannot be discounted. So we all know the unfavorable aspect of CABG. The best conduit for bypass surgery is the lima to LAD, possibly if done well. So for me, the most simple guideline is if the surgeon can do a good lima to LAD, for me he is a good surgeon. The lima, if done well, anastomosed well at the right point in the LAD, has the potential to grow, supply the entire heart. Even if all the other arteries close, it can supply the whole heart. And the lima can last a lifetime. So the worst performing grafts were the radial artery and the saphenous vein grafts. So I will not say too distant a future, bypass surgery was possibly indicated for multivessel disease, left main disease, multivessel with complex lesions, and then angioplasty was initially planned for type A lesions, small lesions, then it came multivessel disease, then we started doing complex PCI, and then CTO, of course, and then single vessel disease was the one to start with. And now the spectrum has expanded. Almost everything is covered under angioplasty. So I would like to share a few cases here, and they are very good cases where we did over the last several years. First patient came with acute coronary syndrome, and it's not playing again. You see the left main disease, and there's a tight OM, which was the culprit here. So we stented the OM, and we also stented the left main. So this patient came in acute situation. That is why we attempted this. Otherwise, this patient should have gone for surgery. So 6 months later, I did an angiography on this patient, and you see the good result. He had an old interval infarction. 6 months later, this patient develops a tight ostial circumflex disease, and because of the old interval infarction, he had a disease at the LAD diagonal ostia, and so this patient we sent him for surgery. So we did take care of the acute situation, but on a long-term basis, this patient was a diabetic, multivessel disease, right coronary artery also was total. He underwent surgery and he is doing well. Next patient was shifted to us from a periphery. If you see a very difficult anatomy, this patient for most people would be sent for surgery because the LAD is flush, tight ostial, and very difficult to stent such patients. And if you see, there's one more area here, possibly Harbinder and you would partly decipher this. This area also lacks a vessel. So if you see, there is a very small artery here which is totally occluded. So this patient had mitral regurgitation, heart failure, and a low LV function. So we thought this mitral regurgitation could be taken care of because this was ischemic possibly. So we stented his OM, and to our surprise, this OM was a very long vessel, and this is what is the technique that I have described. It's called balloon occlusion side branch stenting. We did an ostial stenting of the OM, and if you see, the OM is a pretty long OM, and the length of the vessel decides the importance of the vessel. So this patient did well over 48 hours. His mitral regurg was minimized, and then we attempted the angioplasty on the LAD. So a very tricky angioplasty where you actually would be difficult to place a stent at the ostium, or you place a stent in the left main straight away. So we did the stenting of the ostium and also stented the large diagonal. So these are the IVUS pictures which I would skip and go ahead. And this is the angiography at 10 months. To our surprise, the vessel was wide and open, and the LV function improved, and the patient went home. Another patient with ostial left main disease, almost a sure shot bypass surgery for most cardiologists. This patient was in cardiac shock, BP was 80, and I was out. So I said, you just put a balloon pump and leave it alone. So on a Sunday we came back, we did an angioplasty, and a very short left main, so it becomes tricky at some point of time. And this was the final result. And this balloon pump we removed on the table. So revascularizing this patient, the benefit was so huge that the patient's blood pressure improved by leaps and bounds. So we could remove the balloon pump on the table, and we had the privilege of doing an angiography on this patient at 6 years. She came back with some unknown origin pyrexia. So I said, let us do an angio, and to our surprise, beautiful result. So very rewarding in this situation. This was a patient I did at Bhaktivedanta when I was there. So he came with cardiogenic shock, and if you see, there's a long left main, tight LAD and tight circumflex. So in an acute situation, I thought we can offer an angioplasty. So we did a DK crush on this patient. If you see the pressure recording on the right side, every time I would inflate the balloon, the BP used to go to 50, 60. So very challenging to do a very quick procedure here. So we could do this, and extremely good result on an acute basis, on an immediate basis, and we followed it up at 9 months. Was very good, and this lady continues to do well. Another patient with tight ostial circumflex and ostial LAD. Again, a very clear-cut patient for surgery, and this is also calcified lesions in an 85-year-old plus man. He just refused surgery. He was also in atrial flutter, if you see the movement of the heart. So we did a rotablator on this gentleman, and was very rewarding, very good result at the end. This is the final result, and we also had the privilege of doing an angio on him. So a sustained good result at the end of 1 year. So these are patients where I would like to emphasize that, when you have difficult situations, this patient was celebrating his daughter's pre-engagement ceremony, had a sudden collapse 2 times, and was brought to us in an emergency at Nanavati Hospital. This is about 8-9 years ago. We did an angioplasty on the left main, and patient continues to do well. We did a recheck angio after 1 year, and there is some disease at the end of the distal left main. The patient did not undergo a repeat procedure. I wanted to do an IVUS here, but he refused, and he is following with a cardiologist. Every year he calls me on that date, "Doctor, I am doing well." So that is great satisfaction. So last patient I would show, this is another very tricky patient, came with antrewall non-acetylation MI, a trifurcation disease, which is again a very classic indication for bypass surgery. So this is one of the very rare patients where I have put 3 stents in a trifurcation. Otherwise, 3 stents in a trifurcation are not indicated because they are prone for increased recurrence. This patient was a professor in one of the colleges in Vile-Parle and has since shifted to Calcutta. Is doing well. Very rewarding result. So, angioplasty is technically challenging in these subsets, but yes, over a period of time, every cardiologist gains experience, expertise, and has the knowledge to perform in that setting. Not going ahead, yeah, sorry. So, post-bypass surgery and post-angioplasty, ready to go home. End of day 2, the angioplasty guy is possibly holidaying somewhere, and the other patient is just in the hospital. So, today I don't think there is any hesitation in attempting a complex angioplasty because we have the technique, we have the modalities, rotablator, IVUS, OCT, FFR, already. It's only the cardiologist who should have the courage to go ahead, and if there is a problem, he should not hesitate in calling for help. I think that's the way to go forward. Thank you. Any questions we can answer now or maybe later? So whatever.
Hello. I think Dr. Bhagwat has given the good elaboration and conclusion for what we always face the problem, CABG and a complex angioplasty. With his experience and whatever the elaboration he has given, I think the next cardiology era will be more with the angioplasties than as CABGs. Because the advantages, pros and cons of both still debatable, but as he rightly elaborated, that the experience and good setup and patient choice, patient selection definitely has the better future for the angioplastic cardiological management in future. In Indian scenario, again, the surgery is always avoided by the patients we face across. So this is also a good option. But I would like to ask you one question. As against the angioplasty and a bypass, it's a patient choice or it's a cardiologist choice?
Yeah, so it's a good question. I always, this is my opinion, people may not agree with me. So, if the cardiologist who has done the angiography is competent enough to do a complex intervention and he offers the patient, he convinces the patient, then possibly can go ahead. Now, if the cardiologist who's done the angiography is not so well versed with complexity of disease and he sends the patient for bypass surgery straight away, even if a good angioplasty can be done in a different center with a little more able hand, then the opinion of the first cardiologist sticks. I have seen several times, it has happened to my brother. My brother was a director of Kanpur IIT. It happened to him. They did a bypass surgery on him when there was distal disease in the LAD, where there was no flow following bypass surgery. He died post surgery. Why? Because the cardiologists in Kanpur, they said bypass. But bypass you can't do because there is the whole LAD beyond distally is full of disease. So there are situations where, a little application of knowledge, mind, and if there is a doubt, dilemma, consult, call for help. There's no shame in that. So I feel that today in a situation, with experience, almost all lesions can be tackled, and a very simple guideline. If you have large vessels, always think of angioplasty. If you have small vessels and diabetes, possibly surgery, yes. But at the same time, if you have diffuse disease, surgeons can't do anything. If you graft a diffusely diseased artery, there is myocardial edema post-surgery and there is severe LV dysfunction. There is no flow and these patients don't come out and there is perioperative mortality. So I feel that patient education is the doctor's responsibility. But there are very clear indications now. I would say small vessel and diabetes, yes, bypass surgery is definitely better. But small vessel with diffuse disease may be medical therapy and a limited angioplasty. Large vessels, always angioplasty first.
Any questions from Dr.?
May cost up to 5-6 lakhs also, but bypass is sometimes a favorable option in for patients.
So I think expenditure you should take it out in this current scenario, because the cost of angioplasty, a difficult intervention, has gone up primarily because we are using everything new. Though the government has cut down the rates on the stents, the other rates have not been cut down. And if you go to corporate hospitals, all of them are charging MRP. So that is one of the reasons for increased rates. So I think that is one big factor. Any good surgeon, bypass surgery also is 7-8 lakh rupees, easily. Gone are those days where surgery is done in 1-2 lakh rupees. 1-2 lakh rupees surgery kidhar bhi nahi hota hai abhi. So I think 5-6 lakh rupees, and the patient pays for the job that the surgeon does. The patient pays for the job the cardiologist does. So any good surgeon, minimum cost of surgery is at least 7-8 lakh rupees. At the same time, if you do multiple angioplasty in a corporate hospital, it is exponential. I would say Nanavati hospital. Similarly, I go to Dadar. It's a cooperative hospital where I control the rates and I whatever. So the cost of angioplasty is straight away 40% less at Dadar. So a few patients that I have showed here, I have done at Dadar. So it's a very small place. May not be, the surgeon is not all the time ready there, though we have a theatre. But I think if you have the expertise, we can do. So angioplasty now is lot of technology. IVUS, FFR, OCT, IVL, rotablator. So all that is expensive, and this is all use and throw. So use and throw has definitely increased the cost. There are some European countries who are still reusing, but we don't do that. So that is, I think, the primary reason why the cost has gone up, and of course everything is new. So.
What is your take on ostial LAD left main?
Yeah, so ostial left main is, in the word of the expert, it's a 5-minute job. But the point is, the placement has to be perfect, and you are allowed to have a very small segment, maybe a crown of the stent outside the left main ostium, so that you don't miss. So any ostial lesion of any artery, especially left main, is a little technical challenge sometimes, and any newcomer in angioplasty should call for help. And with experience, I think everybody does it. So it's there are some special tools to be used when you do. You just can't put a stent straight away. You have to prepare the ostium, because ostium has got more muscle, so it's more challenging. It doesn't yield to balloon so easily. Yeah.
So what are the latest guidelines about the antiplatelets management of multi-vessel stents, and how do we control during any surgery or procedure?
Yeah. So as I told you in my presentation, aspirin is going to be history in the next few years. It's already history with some centers in Europe where they use only clopidogrel and no aspirin. But we don't use that because our patients are not so rigorously followed. Our patients don't come back, they don't communicate with us so easily. So we are scared of certain sort of stent thrombosis and all. So and more so, the techniques are so good. We're using IBUS OC2 specially to see how the stent is fully expanded. So when you expand the stent fully, there's no real need to have a DAPT on the, So especially in large arteries, larger the artery, less the option for DAPT. But still we use DAPT because we don't have an Indian trial and we have diabetic patients. We don't know how it works in diabetic patients. So I think possibly in the next few years aspirin will be history. So in acute situations, I always prefer to use prasugrel and Prilenta. There's a small issue with clopidogrel. There are studies which show that there is a resistance to clopidogrel in diabetic smokers. So we are scared of that. So that is why my antiplatelet therapy of choice is prasugrel in all acute situations. On all patients who are at low risk, below 70-75. And I don't use Prilenta so often, but it's more of prasugrel. And once the 3, 4, 6 month period goes away, then I switch over to clopidogrel.
If there is a 3-vessel disease, you will do all the 3 vessels same sitting, or do main vessel first?
Absolutely.
And the other to
So if the patient comes with acute coronary syndrome, anterior MI, inferior MI, posterior MI, I would do the culprit artery first. And if the LV function is good, reasonable, I would, before the patient goes home, I would do the other vessels. That is primarily to save cost, because repeat hospitalization, the repeat procedure is going to be as expensive. Or if the patient has a low LV function, the risk is high, I would stage it.
I think Dr. Bhagwat has almost cleared all the queries raised by the audience. And with his knowledge, what we have learned, more and more days, the adventurous cardiologist, the better setup and newer techniques which are coming up, the angioplasty will, in a future, will take over the bypass. But those certain deserved candidates will require the CABG. I think this is what the take-home message from today's is. And thank you very much, Dr. Bhagwat, for the comprehensive information given.
Going with the next talk is going to be about lipids. The topic is contemporary lipid therapy, integrating novel agents and LPA insights. The speaker is Dr. Harminder Singh, and our moderator is our own Dr. Suresh Sonavne sir. I would like to invite on stage Dr. Sonavne sir. He is MD from KM Hospital, Mumbai, and has been a consultant physician at Sanjeevani Hospital since '95. Now he has his own Sankalpa Hospital, which is in Virar West, and he's been practicing since last 30 years with main interest in critical care medicine. So please come on stage. It's very kind of him to attend this CME today with this trauma. He's been recently out of the hospital, had an ACL injury. And I would like to tell everyone, well, it's a sports injury. So sir has been very active. He plays badminton. And with this, he's still active. Mike. So would you like to introduce Dr. Har?
Dr. Harvinder Singh, basically he's a MBBS from Delhi and MD from AVMC Pune. He has done DM from AIMS Delhi. He's in Indian services last 26 years, and he's a professor in cardiology in Bhaktivedanta Hospital. Still working in Bhaktivedanta Hospital and his own midways cardiac clinic. Today is going to speak on contemporary lipid therapy and newer lipid agent and lipoprotein. I advise Dr. Harvinder Singh to start your speak.
Good morning, everybody, and thank you to the president of Palghar API chapter, Dr. Deshpande, and my friend Rajiv Sharma to call me here for this deliberation. It is indeed a pleasure. I am really enamored by the vastness of this hospital. It is indeed a pleasure to be here. Now, lipid therapy, I unfortunately don't have much good slides and good visuals to share with you. It will be more of a revision for all of us, because I think as physicians and cardiologists, we are treating hyperlipidemia for last many decades. But a lot is happening, just like drugs are coming for all kinds of diseases. So lipids have also seen tremendous amount of advancement. So I will just try to simplify a complex topic like lipids, because it doesn't stick in our minds. We remember the practical aspects, but we forget the theory and the various concepts behind it. So it will be more of a kind of revision. Now let me ask a simple question. Which lipoprotein is made by the liver? We have 4 choices: LDL, IDL, VLDL, remnants, or HDL. Anybody would like to venture? I can hear LDL. Any other options? Yeah, VLDL, correct. Correct answer is VLDL. LDL is not made by the liver. It is manufactured in the periphery, in the circulation. Where is HDL synthesized? Is it in the liver, intestines, endothelial cells, macrophages, or anywhere else? Anybody would like to venture into the answer? It is actually in the intestines. So if LDL is not made in the liver and statins act in the liver, how do statins reduce LDL? The answer is complex, but I'll show you. See, we treat very effectively, but sometimes, the basics also will be very handy in trying to understand why we give a particular drug and what is the mechanism behind that. Let me just revise very briefly. Don't be intimidated by the slides. See, the only lipoprotein made by the liver is VLDL. It is synthesized from cholesterol, triglycerides, phospholipids, and ApoB. ApoB is the bad apoprotein seen in all bad lipids, starting from LDL and all those things. So VLDL keeps circulating, there is an enzyme, lipoprotein lipase, it keeps delivering triglycerides to all the cells because it is the source of energy. That becomes ideal. And as the triglycerides are delivered in the periphery, the cholesterol content of the molecule of VLDL keeps on increasing and it becomes more and more dense. It becomes LDL. Finally, LDL is taken up by the liver. See, liver, please imagine, liver is an organ which is producing cholesterol as well as excreting cholesterol. But liver must get a lot of cholesterol. Liver is hungry for cholesterol. I'll show you why. And that is the basis of many of the treatments. So LDL is taken up by the LDL receptor and liver gets the cholesterol which it wants. Now this is how these are the LDL receptors. This is the LDL receptor. The LDL comes, joins the LDL receptor. It is internalized as an endosome. It is broken down, cholesterol is released, and the LDL receptor goes back to the surface again. There is another enzyme called PCSK9. Now, job of PCSK9 is to keep destroying the LDL receptors. Very difficult to understand. LDL receptors are required, but there is something to destroy it also. So it combines with LDL receptors and it destroys. Then why nature has made PCSK9? The reason is because body must ensure delivery of cholesterol to all tissues. Each and every cell needs cholesterol because it's part of the cell membrane. So from this you can understand the LDL levels are controlled by the presence and number of LDL receptors. It has nothing to do with manufacture of LDL or manufacture of cholesterol. Now, how is small dense LDL? See, if the LDL keeps on becoming smaller and smaller with greater and greater concentration of cholesterol, it becomes more atherogenic. Small dense LDL is seen in hypertriglycerides, insulin resistance, diabetes, high carbohydrate intake, and low HDL levels. And as you can see from this, all these features are seen in our Indians. So we have hypertriglyceridemia, insulin resistant, everything is seen. That is how Indians are prone to have small dense LDL. The clinical significance of small dense is very atherogenic. Smaller the particle, it can go into the macrophages and the arterial wall very fast. And it stays in the circulation longer because it has less affinity to the LDL receptor. So, and therefore it causes more atherogenesis. Now HDL, briefly I will say, it is synthesized or manufactured in the intestines. Now here the apoprotein is A1. Whenever you see A1, it is good to have more A1 and less of B100. It keeps on circulating. The HDL particle is like RBC. It is absolutely flat. But as it keeps on circulating, it keeps on picking cholesterol from the periphery and starts getting swollen and becomes round. And finally, it is again taken up by the liver by this specific receptor, which I don't want to go into detail. And then some of it keeps recirculating, goes back into the circulation and gets more cholesterol from the periphery. So whatever cholesterol is delivered by HDL is liver excretes it into bile. Now, part of my topic is LP little a. LP is also like a LDL particle, but it has some additional surface markers which makes it very similar to plasminogen. Here apolipoprotein A is the apolipoprotein, small a. So it keeps competing with plasminogen. So it reduces plasminogen, so reduces plasmin. Therefore, fibrinolysis will be reduced. As a result, it promotes promotes thrombus formation. So LP little a is atherogenic as well as thrombogenic. It is synthesized in the liver, has a long half-life, and 90% of the levels are controlled genetically. There is no role of diet, exercise, or any other thing. Then why nature has made such a dangerous molecule? Because it is helping in wound healing and tissue repairs, and also cholesterol transport. So LP little a is in the normal values is required. However, it causes premature coronary artery disease and aortic stenosis. The calcific aortic stenosis that we see, many of them are produced because of high LP little a. The normal levels are less than 30 milligram, and more than 50 milligram is called as high little a, and it is considered to be atherogenic. Now cholesterol, now we'll concentrate on the cholesterol synthesis. So far I have summarized the lipoproteins that are there and which we measure in the lipid profile. Now cholesterol, these are all the genes which regulate cholesterol synthesis, out of which the main is HMG coenzyme A reductase, where statins act. But you can see cholesterol manufacture is genetically controlled. So whatever serum cholesterol you are seeing, 90% is genetic, 10% to 15% is related to diet. Now there is a condition called familial hypercholesterolemia that is very important to recognize. We keep seeing such cases in so familial hypercholesterolemia is again a genetic condition which can be due to problems in LDL receptor or ApoB genes or PSK9 genes. However, 90% of cases of familial hypercholesterolemia are due to LDL receptor gene abnormality. Now, what are the physiologic functions of cholesterol? We all know this. So many cholesterol dependent hormones are there. Bile acid synthesis, membrane fluidity, lipid serum level, precursor of vitamin D, plasma lipoprotein constitute, and most importantly, in the brain, the myelin of each and every neuron has cholesterol in it. So it is very important. But mind you, to fulfill all these functions of cholesterol, we need very little. So if you have serum levels of cholesterol 300, that's not required for meeting all these functions. Now we have multiple cholesterol lowering drugs. I will show you where do they act. Cholesterol lowering drugs need not act only on cholesterol synthesis. They act elsewhere as well. Now this is the cholesterol synthesis pathway. I will not go into the detail. Very early, the Krebs cycle, an offshoot of Krebs cycle is cholesterol synthesis. Bempedoic acid acts very early in the synthesis. The enzyme ATP citrate lyase. And finally, when it comes to HMG coenzyme A reductase level, that is where the statins act. So in the same pathway, we have two cholesterol lowering medications. Then we can have cholesterol lowering drugs in the enterohepatic circulation. So cholesterol from the diet and coming from the periphery through LDL is converted into bile acids, which is secreted into the bile, and cholesterol directly also is secreted by the liver into the bile. That is how we get cholesterol bile stones, gallstones. And then it is reabsorbed. Both the things are reabsorbed. There is two enzymes, ABST and this particular enzyme, which absorb bile acids and cholesterol back, and it goes into the enterohepatic circulation. Now this can be blocked by ezetimibe. Ezetimibe acts on this NPCE1L1 enzyme. And we can also lower cholesterol by targeting the LDL receptors. We can destroy the LDL receptors by PCSK9. If we block PCSK9, LDL receptors will not be destroyed and more LDL will be taken up by the liver and excreted into the bile, and serum levels will fall. So these are the sites where the drugs act: bempedoic acid, statins, cholestyramine, ezetimibe, and PCSK9 inhibitors. Now triglycerides also very important to understand. We get triglycerides from three sources. One is what we get from the diet. This is here. The liver is manufacturing triglycerides, and we are getting from the gut in the form of chylomicrons. All the fats are absorbed in the form of chylomicron. Once triglyceride is synthesized, it is packaged into VLDL only, and as the VLDL passes through all the tissues, lipoprotein enzyme keeps on releasing triglycerides into white adipose tissue, brown adipose tissue, muscles, heart, brain, everywhere, and then what is left comes back to the liver. So these are the sites where the drugs can act. They act on lipoprotein lipase, which is mainly phenofibrate, on lipolysis in white adipose tissue, this is niacin, and we can have many drugs like omega-3 fatty acids suppressing the triglyceride synthesis. Now coming to the cholesterol and triglyceride lowering drugs. These are the list, we all are aware, and I am sure we have used these drugs multiple number of times. To save time, I will not discuss about statins, which is very well known to all of you, except pitavastatin, which is little different statin. I will give you the insight. Ezetimibe is a very old drug, but has some new role given to it. Bempedoic acid is relatively new. PCSK9 inhibitors are very new and not well understood and not much used because of cost. And on this side again, I will discuss one or two drugs. Now statins, we know they inhibit this particular enzyme. They reduce production of cholesterol, but LDL does not reduce because of that. Statins lead to increased LDL receptor density and clearance of LDL, and LDL levels fall. So I will highlight a little bit about pitavastatin. It has very high bioavailability and it's very potent. 1 milligram is equivalent to 10 milligrams of atorvastatin. It has least drug-to-drug interactions because it does not act on cytochrome P450. It is excreted in bile, so it is very safe in renal patients. And it has significant efficacy just like any other statins. So about 30%, 45% reduction in LDL, reduction in triglycerides, and marginal increase in HDL. It is glucose neutral. We know statins worsen diabetes and can also have a small incidence of new onset diabetes. Pitavastatin doesn't do that. Least drug-drug interactions, and the only limitation is there are hardly any studies. There is hardly any outcome data on mortality and morbidity. That is why as cardiologists we are not using it very often because we depend on atorvastatin and rosuvastatin, which have very, very robust data in all kinds of manifestations of coronary artery disease and stroke. Lp(a) is very difficult to treat. Levels don't change by diet, by exercise, by any statins to a significant degree. So only thing which really works is the PCSK9 inhibitors, which reduce it by 20 to 30%. Niacin also reduces it by 20 to 30%, but there is no proven outcome benefit. That's why niacin has not come in the guidelines for treatment of Lp(a). Ezetimibe and other statins hardly do any change to Lp(a). So Lp(a) is a very, very difficult thing to treat. The levels are genetically controlled, but a lot of emerging therapies are coming. In the next 1 or 2 years, we'll see pelacarsen coming as one of the drugs because they reduce the Lp(a) by 80 to 90%. Bhaktivedanta Hospital is one of the centers for Palghar study which is going on. So we hope to contribute few cases for this study. So this is the Palghar is a drug to be watched in the next 1 or 2 years. Ezetimibe, we all know, I'll just say that it inhibits this particular enzyme on the brush border of the intestines and prevents absorption of cholesterol. This is as a first add-on to statins. If the statins are failing in any way to achieve the targets, ezetimibe is the first add-on therapy. So there are some studies, I will just skip them. The only thing is it helps us to reach the targets, but there is so far no mortality benefit accrued because of ezetimibe use. So you can see the very marginal separation of this thing. So only 17% relative risk reduction in the trials with fenofibrate. So it only helps us to reach the target, but not changes any mortality. Bempedoic acid is being increasingly used. This is where it acts. However, I want to highlight that same pathway also, which goes partly into triglyceride manufacture, that is also blocked by bempedoic acid. So it reduces triglyceride as well as cholesterol levels. And it also has a reduction of the inflammatory markers, and there is a significant fall in hsCRP. And so it reduces inflammation, reduces triglycerides, and of course reduces cholesterol. You can see the fall in hsCRP is to the tune of 44%, which is very, very good. And LDL, it reduces about 22% when used alone. But when you use bempedoic acid with statins, there is 25% reduction. Bempedoic acid plus ezetimibe, 38%. But if you use statin, ezetimibe, and bempedoic acid, fall is as much as 60%. So these three combinations is poor man's PCSK9, because PCSK9 achieves something similar, about 60-70% reduction of LDL. So if you combine these three, we can call them as poor man's PCSK9 inhibitors. Gout is a major adverse effect of bempedoic acid. PCSK9 inhibitors, I have the pleasure of using only in one patient because my patients cannot afford it. I have already shown you the concept behind it. The drugs available are those drugs which destroy PCSK9. So these are monoclonal antibodies. Since antibodies are cleared very fast from the circulation, their duration of action is not more than 2 weeks. We also have inclisiran, which is small interfering mRNA, which reduces the production of PCSK9. Since it is at the level of synthesis, the effect lasts for 6 months. So inclisiran can be used 2 injections in a year, every 6 months 1 injection. The indications of PCSK9 is secondary prevention, where the risk is high and we are not reaching the targets. In acute coronary syndromes also, immediately after MI or immediately after acute coronary syndrome, we can give them. Familial hypercholesterolemia is the best possible indication for this, and Lp(a) is reduction is very, very modest, about 20 to 30%, but that's also a recognized indication. So these are the drugs available. We have Repatha, we have inclisiran, and every 180 days we can give this particular drugs. Among the cholesterol lowering options, if the goal is not reached, increase to high dose statins. If still not, add ezetimibe. If still not, add bempedoic acid, and finally PCSK9 inhibitors. But if this patient is statin intolerant, you can reduce the dose of statins, add ezetimibe or bempedoic acid. triglyceride lowering is phenofibrate. It acts on the lipoprotein lipase through PPA alpha agonist. It is very highly efficacious. The side effects are, the dose is important. I would like to say if it is a normal preparation, the dose is 200. If it is micronized preparation, you can reduce it to 160. But if it is a nano formulation, it is 145. So various drugs are available with various strengths. This is the reason. Omega-3 fatty acids, they act on everywhere where triglycerides are produced. And out of these, the newest addition to our armamentarium is icosapentile ether, Cosatil and Biosia. These are two brand names available to us. The dose is 2 to 4 grams. Smaller doses do not act very well. So in severe triglyceridemia, 4 grams per day, that is 2 gram BD, should be the dose. Niacin is very, very helpful. It reduces LP little a also, but mainly it is used for high triglyceride levels. And sustained release formulations, we start with 500 milligram and every week step it up along with aspirin, which reduces the flushing side effects. Saroglitazole, I think I am exceeding the time, so I'll just go fast. Saroglitazole is an Indian drug made by Indian scientists. It has similar action. Only thing is it has additionally insulin sensitizing effect. So insulin resistance is taken care of and that reduces triglyceride levels. It reduces 40 to 60% levels of triglycerides are reduced. Now quickly the goals are we should give high intensity spontaneous coronary artery disease which is established. In general population we should keep it LDL of less than 100. If already established heart disease is there and diabetes, keep it around less than 70. If there is disease in two vascular beds, that is peripheral arterial disease, stroke or coronary artery disease, any combination of two of them or more, we should keep it around 55. And despite statins, if there are recurrent events happening, recurrent ACS, recurrent problems, then we can go down to less than 40 or less than 35 even by as per the Indian guidelines. So to conclude, lipid management is crucial to management of ASCVD in all its forms. Statins are the mainstay. Recent availability of bempedoic acid, ezetimibe and PCSK9 inhibitors has changed the scenario considerably. Simultaneously, we should also work on triglyceride levels. Thank you very much. So I know lipids always a boring topic. So
Dr. Harminder Singh's nice speech on lipid management. Anybody want to ask the questions?
Excellent talk, Dr. Harminder.
Thank you, sir.
Really, you took us around 35-40 years before to the biochemistry department of first time APS. It was amazing. I just want to ask you regarding this LPA. You already spoke that there are a lot of trials going on for LPA reduction and followed by, does it really give us a beautiful beneficial effects post after reduction of LPA? And as a physician, shall we really start practicing or putting a LPA in our day-to-day practice? Your comment.
See, doing LP little a is important, especially if you have premature coronary artery disease, young patients who are coming to us with MI, acute coronary syndromes, those who have family history. This is very common. Many members of a family suffer from ACS. So in all these patients, doing LP little a is important because that increases the risk. Now, once you identify LP little a, people may say you can't do anything about it, why test it? But if LP little a is high, all our other interventions must be very, very rigorous. That means lifestyle modification, control of blood pressure, diabetes, and use high dose statins. So if we cannot reduce LP little a significantly, at least we reduce the risk by other means to as low as possible. As far as whether Palghar, which is the first trial to my mind will be published next year, whether it will show mortality benefit, it is very difficult to say, because many trials have come, and many drugs have come and gone, like HDL trials or Citrapib. Everybody was so excited that we are increasing the HDL, but that increased the mortality. So what will be the ultimate, we cannot say.
Good morning, sir. I
Yeah.
would like to ask one more question. My question is, LPA pheresis is one of the new technologies these days. So the patients who are very much genetically susceptible for the high LPA, what is the role of that in India in a near future?
See, India apheresis, I don't think we should get excited about it, because it has to be done. It's a costly thing, not available. I think it is available in KEM, if I am right. But it has to be done periodically. LPA levels have to be monitored. And I don't think many of our patients will be keen to do that, or probably won't be able to afford that.
Good revision, Harvinder.
Yeah.
Good, because concepts should be revised all the time. So the only oral drug for LPA is going to be Multispeciality. So all other drugs are possibly injectable. So Multispeciality is being, I thought it should have been launched by now, but then Lilly is trying to do it. So that's the only oral one which possibly would have. And LPA, the new recommendation is once in a lifetime of every patient, individually you should do it. That's a WHO guideline. And it hardly changes, it just changes by 10% in each individual. Niacin and other, as Harvinder mentioned, reduce it by around 30%, 25 to 30%, but then it remains stable. So what helps is aggressive reduction of LDL cholesterol gives you cross benefit towards LPA. Because LPA basically is LDL and an ApoA protein. So aggressive reduction in, so of course, we have not done any study, but that's what the recommendation is. Yeah.
Yes. Thank you.
Any particular patients that you do genetic profiling, almost like the cytosine mutations for dyslipidemia? Younger guys with dyslipidemia. Do you do genetic studies?
Yeah, I have done in few. So where you suspect familial hypercholesterolemia, there is a scoring system to diagnose that. If patient is fitting into familial hypercholesterolemia, then we should do it. Because if that is positive, we should screen their children in the family starting from, say, teenage age onwards.
What is the cost of this, sir, and where do we send the samples, sir?
See, name of the company I am forgetting. I have the number of the person.
The hypertrophic cardiomyopathy wala
same person. So I have done in hypertrophic cardiomyopathy many times. 2 cases I did for hypercholesterolemia also, and both of them came positive. The cost is around 16,000-17,000 rupees.
Thank you,
Yeah,
sir.
it is simple blood test. They come and collect it, and then you get the report in about 7 to 10 days.
Hello, sir. Any drugs for increasing HDL?
HDL is increased by many drugs. The simplest is physical exercise. Physical exercise, stoppage of smoking, then statins increase by about 10%, fenofibrate increases by about 20% or so, and niacin also increases by about 20-25%. So there are many of these things, but still in Indians it remains low. You see, 10% of, say, somebody's HDL is 30. So 10% increase means it becomes 33. So you will not even come to know whether it has increased or not, because as it is, there is so much of variability in the lipid profiles. One lab will give you 40, the other will give you 30 for the same patient. So the increase is very minimal. It's not very visible to you on the lipid profile reports.
Doctor, I have to ask one question. You have presented a very good presentation in army style. Thank you very much for the same.
Thank you,
One
sir.
more thing. Now, just now you said that these cholesterols are being controlled by the genetically. And if it is 90% controlled by genetically, don't you say that the statin use is overemphasized in India? In
What,
this case,
what is overemphasized? Say again?
overemphasized?
What?
Because we only statin groups of these medicines are given too much to everybody.
No,
When
sir.
the control itself is not there.
See, the serum levels are genetically controlled. But as a therapeutic option, we have to employ statins.
Now, do you mean to say that the use of statin here is actually justified?
100%, sir. For secondary prevention, you cannot escape statins. For primary prevention, we can have a debate. In high-risk patients, those who have family history, those who are diabetics, those who are prone to other multiple risk factors like diabetes and other blood pressure, obese people, their primary prevention can be slightly debated, but for secondary prevention, we cannot omit statins. Dr. Bhagwat wanted to say something.
I want to add to what Dr. Harminder has said. See, there are 3 drugs in the entire pharmacology sector linked to cardiology, which have pleiotropy. Besides the main effect, they have good side effects. One is aspirin, the number 2 drug is amipril, and number 3 is statin. So if you go to the pharmacokinetics and the actions, this comes under pleiotropic effects of these drugs, the good side effects. So statins, as Dr. Harminder mentioned, not only reduce the LDL synthesis, they are basically anti-inflammatory for the coronary. So that is a high dose statin. We have seen, I can't say plaque dissolves, but yes, in a way, the plaque regression is so fantastic. I've studied patients with a CT scan, 30-40% soft plaque, high dose statins, plaque disappears. So you cannot discount that effect. So besides that, they also have little antiplatelet action. They also increase nitric oxide in the endothelium. They also anti-restenotic. So there are multiple effects of statins. Statins also promote calcification in the plaque. So now calcification, it's actually, they say it's a good calcification because it stabilizes the plaque. It not only reduces the lipid pool in the soft plaque, but that replaces the lipid pool, it hardens the plaque, and it changes, it interferes with the calcification mechanisms of the vascular tree. So they harden the plaque, and that is the way it promotes calcification in the coronary tree, but it's supposed to be good calcification. Yeah. So I think you should go through it. They're very good drugs. Yeah. So besides lowering statins, the main effect is anti-inflammatory. So if you see in an acute coronary situation, you may find multiple lesions. You restudy this patient after an angiogram or do a CT scan, you will find that coronary tree has become near normal. We have seen several patients. Yeah.
After starting statins, how frequently you will do blood tests to determine the level of cholesterol and other?
See, if the lipid profile is normal, I think we should do it yearly. However, if it is very high, say in the range of LDL 200 and above, then we give the statins, high dose statins, and check after 1 month whether they have come to a reasonable level. Then 3 monthly we can do it. Once we are sure that the patient is compliant, his statins have reduced the LDL to the target level, then we can do once in 6 months or even annually we can do it. So depends on the clinical picture.
Lipidology is such an interesting topic. We can go on and on. I think even one day, we can keep a one-day workshop on lipidology, because once physicians know more in depth about this, I think we can save a lot of lives. So thank you so much for that wonderful, enlightening lecture.
Thank you.
One last question, Harmin.
Yes, sir.
With what LDL level you are comfortable in a vascularized patient, the one who has you have done the PCI with him, and with what LDL level you will be comfortable?
Less than 70, definitely less than 70.
Less than 70.
Less than 70.
Okay, thank you.
Yeah. Thank you, sir.
Besides sir's knowledge, there is one more aspect that I would like to share. Sir has served the Indian Army, AFMC. He has worked there for 26 years. So big round of applause for that. Moving on with the next session. So we have this about now acute heart failure management, from stabilization to optimization. We have our own speaker, Dr. Venkat Goel. Sir, please come on the stage. And the moderator for this session is Dr. Rakesh Patil, sir. A small introduction about Dr. Rakesh Patil. He's been practicing in Vasai Virar area since over last 10 years. He's DNB in medicine from BRC and owns Dr. Patil's Diabetes and Heart Care Clinic. He was an intensivist at Kokilaben Dhirubhai Ambani Hospital and was attached to Vijay Vallabh Hospital also and our own Riddhi Vinayak Hospital. Besides academics, he has published a poetry book called Rhymes That Rock, that has been the winner of the 21st Century Emily Dickinson Award. So,
thank you.
Sir, please introduce Dr. Goel, sir.
Yeah, so Dr. Venkat Goel, sir, obviously needs no introduction, but definitely we'll go through his achievements. Sir is a consultant cardiologist and the CEO, Riddhi Vinayak Multispeciality Hospital, interventional cardiologist with special interest in heart failure and minimally invasive coronary surgery, fellowship in 2006 in Berlin, started ECMO Society of India in 2010. He's a pioneer in ECMO management of patients, more than 300 ECMO experience in the last 10 years. Also about heart transplant artificial heart diseases center in Mumbai. He's a past president of SWAC, ELSO 2018. Also got the FELSO award in ECMO 2020 by ELSO. So area of expertise is heart failure, ECMO, and minimally invasive coronary surgeries. So I welcome Venkat Goel, sir. And for me, he's a mentor, and today also I learn a lot from him. And I'm very happily associated with the Vinayak Hospital. So I introduce Venkat, sir, for his talk. Thank you.
Thank you, Dr. Rakesh Patil.
Yes, sir.
Respected seniors and friends, it is a pleasure for me and an honor. And I thank Dr. Deshpande sir and Madam Anamika for giving me a chance to speak on this topic, which is very close to my heart. Now, as you have seen that acute heart failure is a burning topic, at least for the last 25 years. And before we start understanding acute heart failure, we have to go through its definition, its staging and classification, pathophysiology, and then the management. I would include the management slides along with the pathophysiology and classification, because then it becomes easy for me to place the drugs properly. And finally, the mechanical circulatory support. Let us go through the fast glimpses. First, the demography of heart failure. Then the concept of acute heart failure, which is not really heart failure, it is acute heart failure, and then the pathophysiology. With the growing incidence and the prevalence of heart failure patients across the globe, with more than 5 lakhs population of annual incidence and a mortality of more than 2.5 lakhs population and a prevalence of more than 22 million population, somewhere even earlier than 2010, and heart failure incidence and the percentage increasing more and more as compared to all-cause mortality, there came a period where we divide this concept of heart failure into 3 eras. from 1975, then 2000, and then 2025. So from 1970 to 1980, there were campaigns against the crusade against heart failure because of the cost concerns. So various trials like this have introduced a new concept in 1990 called as the acute heart failure. Acute heart failure is somewhat similar to the compartment syndrome of an ischemic limb, a cerebral edema of an head injury, or acute renal failure and hypertension, and it is absolutely different from chronic heart failure. Our conventional heart failure education, as seen in our school days, like systolic and diastolic failure, preload and afterload, cardiac versus non-cardiac, forward, backward failure, and abnormalities of cardiac rhythm, are not acute heart failure. These are pathological classification. Then there was an era between 1980s to 2000 of a clinical classification of heart failure, like NYHA classification, CLIPS classification, and Forrester classification. But they were all chronic heart failure with classical signs and symptoms. They had time to set in. They were obviously seen and visible, and they had been classified accordingly, which is something different than acute heart failure. Then what is acute heart failure? Acute heart failure is the hospital management of heart deterioration beyond human tolerance, without classical signs and symptoms, and a very rapid, silent, and a catastrophic progress. This is a compilation of various schools of thought and various trials, and we have a lot to learn from them. So there has been various trials in Europe and America regarding this concept, something known as ADHF trial, or the optimized trial and the concept trial, and Euro heart failure trials. And there were various pathological mechanisms behind them. And those pathological mechanisms involve almost every organ of the body, like cardiorenal, circulatorenal, neurohumeral, neuronal, cardiorenal, etc., which I will cover shortly. And then they come out with a consensus that various societies of cardiology had something in common and something different to define this acute heart failure concept, but they had all agreed upon few things. The few things are what? Now the latest terminology of acute heart failure syndrome consists of two things. One is acute heart failure, and second is acute decompensated heart failure, or acute decompensation of a chronic heart failure. These two things happen when there is an acute insult. Acute heart failure will come with de novo heart failure, like in a diabetic patient, or like with acute coronary syndrome, the patient suddenly, the heart suddenly deteriorate, that patient is an acute heart failure. But when there is a patient who develops fever or arrhythmias or is in sepsis, and he is having a chronic heart failure, and then if he deteriorates, that is ADHF, that is acute decompensated heart failure. So if you have to talk about this percentage is growing alarmingly more, like you have yourself and you have a shadow, the shadow keeps on becoming longer and longer as you don't reach the destination close by. Similarly, the percentage of acute heart failure population is more than 10 times the acute coronary syndrome or coronary artery disease population, because we are mistreating them. We are delaying treatment. Time is muscle, and we are losing time and not properly managing them. So that morbid population is adding to the disease burden, and they live for few years and they die miserably. So this concept has to be learned very clearly by us, and to treat them in time. If you are so much concerned about interventions and angioplasties and thrombolysis, then this is a much bigger demon than the coronary artery disease epidemics in across the globe, that it is much more deadly as compared to coronary artery disease. If I say acute heart failure syndrome is a rapid onset, etiology can be anything, but there are two cardinal manifestations. What is acute heart failure? We talk of congestion and we talk of hypotension. This is the total, these are the only two armamentarium on which the entire mechanism of acute heart failure depends upon. Congestion is dealing with diastolic heart failure. Like I said, every systolic heart failure is preceded by a diastolic heart failure. Every breathless patient after the age of 40 is an early diastolic heart failure patient. Every edema feet, every patient with fluid retention, every patient getting orthopneic is a diastolic heart failure. So that is congestion. Congestion is a part of diastole. For diastole, we do not have much to do. That is the passive return of blood to the heart, and therefore it is purely being managed by chemical means, which is not enough, but that is the only thing in the diastolic part. Congestion has to be dealt with by chemical therapy, and hypotension, hypoperfusion has to be dealt by chemical means, which will only fulfill 20 to 25% of the requirement, then by mechanical support, which I will come to on this later upon. So acute heart failure syndrome deals with congestion and hypotension. This is the very common graph, what we say, the dry and a wet patient and a warm and a cold patient. And this volume status is the congestion part, peripheral perfusion is the hypotension part. And we divide the entire heart failure population into these 4 categories. So once we have cardiac index and when we have capillary wedge pressure, then we can divide the subset into normal, congested, hypoperfuse, congested and hypoperfuse. And then depending upon the score, when to give inotropes, when to give diuretics, when to give vasodilators can very well be decided. So unless you don't know the pathophysiology, unless you have done a proper monitoring, this cardiac index and capillary wedge pressure is not pulse and BP. You will not get to know anywhere. You have to be invasive to get the answer. This patient, much before the patient goes into cardiogenic shock, is already landing into a cardiac index of less than 2 liters per minute, and therefore he will require a different management as compared to inotropes. You may have to give fluid therapy. So this is where pathophysiology helps to stabilize the patient and optimize the patient on acute heart failure concept, which is an invasive modality. It comes so suddenly, it does not give time for clinical signs and symptomatology to come up. So how to quantify acute heart failure? By clinical suspicion, invasive monitoring, BNP levels, very important parameter, echocardiography, proactive management and time consciousness. These are the symptoms and signs which we all have learned so far. And these are the supplementary laboratory investigation. We have to be also mindful about the serum iron levels and thymine levels, which are found to be decreased quite oftenly with heart failure patient. Then the cardiac evaluation in terms of echocardiography, and beyond onwards, all these things are required. BNP, of course, is the cornerstone of heart failure diagnosis. As the heart failure increases, the BNP level rises. There are anamnestic reactions where BNP levels are found to be elevated with renal patients, but by and large, we have seen many patients crossing a BNP level of 10,000, 15,000, and we sit comfortably. So that is what the way our inertia has to get over. We have to start treating them like a reaction we get when we see a raised cardiac marker. Similarly, once you get a BNP about 10,000, you should be on your toes to do something for the patient. And chemical treatment is only fulfilling less than 20% of the requirement of a heart failure, which is a mechanical organ. And for mechanical organ, you require a mechanical support, which may not be always possible, but you have to start thinking. If you say you want to send a patient for a good management of acute coronary syndrome to a good hospital, to a good doctor, similarly for a heart failure patient, you have to send the patient, once the patient goes over to a severe level, to a good place to get a complete treatment of cardiogenic shock, as is defined at many places. So requiring of monitoring, non-invasive monitoring, invasive monitoring. Now these are essential components of managing the patient of heart failure. If you do not have them, then kindly start gearing up yourself, make your center capable enough to get all these parameters on board, have your monitors like that, get your staff trained properly, and monitor these patients accordingly if you want to treat heart failure patients. Other biochemical parameters are all these things written here. Echocardiography is the cornerstone, and the investigations of suspected heart failure are many. Then pathophysiology. Now, these were the definition of acute heart failure. Now I come to pathophysiology. Why is heart failure so complex? It is so complex because as soon as the hypotension sets in, every organ of the body is starved. As soon as the starvation of circulation or tissue perfusion sets in, you have a cascade of reactions. You have a mechanism, at least 24 mechanisms starts activating as soon as the laminar flow of the aorta goes down. And once the baroreceptors and the chemoreceptors in the aorta and the origin of the vessels, they find a hypotension, they initiate a chain reaction, sometimes detrimental, sometimes beneficial, but mostly detrimental. If I take you through the various pathophysiological pathways, then these are the mechanisms of neurohumoral, systemic vascular resistance, cardiorenal, RAS system, endocrinal level, and biochemical. Now, these are the compensatory mechanisms in the initial pathways, then the hormonal mechanism, the sympathetic nervous system, the RAS system, and the vasopressin system, then the angiotensin system, in which the angiotensin get activated, and it has got various deleterious effects in terms of vasoconstriction, oxidative stress, cell damage, proteinuria, and LV remodeling, which starts coming up as soon as the hypotension takes place. And the deleterious effect of angiotensin can be all these many, and these are not seen obviously, but they are damaging the heart, they are damaging the tissues, and the patient is going into an irreversible cell damage or irreversible failure. Then the RAS system, both the ACE and the non-ACE pathways with all the chemical mediators, then the neurohumoral activation of vasopressin, the central vasoreceptors causing a chain reaction of vasoconstriction and decreasing in the cellular perfusion. Then the natriuretic peptides, ANP, BNP, and the CNP levels, they have all the effects, hemodynamic and neurohumoral effects on the veins and the arterioles. Then the endothelium-derived vasoactive factor, the EDRF and the EDCF, which has a vasoconstrictor effect as soon as the hypotension sets in, they all cause secondary damage much more than the primary damage. The natriuretic peptides, the ANP, BNP, and the CNP levels, the mediators of heart failure, the cytokines, the interleukins, and then the sympathetic nervous system causing decreased contractility, tachycardia, and vasoconstriction, which would again further decrease the tissue perfusion. Then they will have the effect in terms of decreased myocardial toxicity, increased arrhythmias, disease progression, and vasoconstriction. These are the levels of the various chemical mediator which is found to be much elevated in heart failure as compared to normal patients. The cardiorenal axis, the intrinsic renal pathway, the vasomotor pathway, and the cardiorenal syndrome, and which will have an effect in pulmonary congestion, in exacerbation of the pump dysfunction, and in terms of increased energy expenditure. So in short, with all these pathophysiological mechanism which sets in, it starts a chain reaction. And that chain reaction would have to be treated differently at different axes. Like if we have therapies of LV dysfunction, these are the drugs, ACE inhibitor, beta blocker, aldosterone, cardiac resynchronization therapy, and they require digoxin, etc. For congestion, salt restriction, diuretic, ultrafiltration, vasopressin. For coronary artery disease, antiplatelet, statins, revascularization. And for atrial fibrillation, rate controlling drugs, digoxin, beta blockers, and other rate and rhythm controlling drugs. For hypertension, ACE inhibitor, beta blocker, and diuretic. So you find a pathophysiological mechanism, you have to treat the things accordingly, what is required for that axis. So in short, pathogenesis and the therapeutic options for the mechanism which sets in, you have drugs all according to them, and you to have all these drugs according to the requirements. So if I have to say, if a classification of heart failure of stage A, B, C, D, or NYHA class 1, 2, 3, 4, then according as the patient progresses from high risk, no symptoms, to refractory cardiac symptoms, we have a step ladder mechanism to go up the pathway and treat the patient with all these possible drugs if required as the patient deteriorates. So in the management of systolic heart failure, the last part is that, as I said, the chemical mediators will treat the heart only by 20 to 25% of the requirement. Rest is a mechanical thing. You can't treat a mechanical thing with a chemical reaction. So for that you require a mechanical support. For mechanical support at the stage between NYHA class 3 to 4 is the recommendation for mechanical circulatory support, and this mechanical circulatory support has many armamentarium. If you are able to use the mechanical circulatory support in slightly early stage between 2 and 3, probably that is the stage where the deterioration and the this pathophysiology would not set in, and the patient can be salvaged earlier, as we said, doing things in time. Then there was a era of cardiac resynchronization therapy from 1975 to 2002, but then also it plateaued. There were non-responders, there were not really, all patients could be benefited with CRT, so that also came to a plateau by the era of 2005. So the time scale, there was awareness of heart failure in 1980, then trials in 1990, the concept of heart failure in 2000, plateau of CRT by 2005, then various morbidity and mortality reductions of various, by the application of various pharmaceuticals in acute heart failure concept. And now we are talking about from 2015 onwards in mechanical circulatory support and other temporary and permanent mechanical support to the heart. Then we come to the classification. As we said, that there are 6 million population in 2012, now about 2003 there will be 8 million population. These are American figures, if I will just pass through that, but the figures are riding rapidly. Let us come to Indian figures. Before I start off Indian figures, let me talk about cardiovascular diseases. There was a new term called as not coronary artery disease, but cardiovascular diseases, because it incorporates all the statistics are now with relation to cardiovascular diseases. Coronary artery disease, cerebrovascular disease, peripheral arterial disease, rheumatic, congenital, and deep vein thrombosis and pulmonary embolism. They all come under the subset of cardiovascular diseases. And the risk factor for cardiovascular diseases has been our unhealthy lifestyle, physical inactivity, tobacco use, and harmful use of alcohol. And they all result into a secondary damage by rise in blood pressure, rise in blood lipids, overweight, and obesity. So therefore, if you look at the world statistics, the cardiovascular diseases scores highest among all cause mortality, being around 33% than other diseases. And if you talk about India, in India, the rate of cardiovascular diseases is around 272 per lakh population of India. And for us, because we are a relatively younger population, our cardiovascular disease incidence is 10 years younger as compared to the world population. And there is a rapid progression of disease and mortality because we are not treating the disease properly. We are leaving many patients of heart attack improperly treated, which is creating a lot of a burden, a residual burden of heart failure population. So premature mortality and loss of quality of years life in India is increased by 59%, which was around 23 million in 1990 has become 37 million. And because of a lower socioeconomic background and improper treatment and not receiving treatment in time, the outcome has been different. So cardiovascular disease in India is the biggest of all. Around 25% of all population of the world is in India. The key fact about the prevalence of heart failure in India is around 1.2 per thousand population. 16% of the world population is in India, but 25% of world's coronary artery disease are in India, and similarly is the outcome. Now we go ahead from epidemiology to classification. The classification has progressed further. From NYHA classification, we came to an era between 1980 to 1990 to ACC classification, ABCD classification. A means only high-risk cases, and D means refractory cases. And they were compared against the NYHA classification like this. So this is the same thing, trying to tell that the established heart failure diagnosis starts from the stage between C and D. And so was the treatment between A, B, C, D stage. The same way, there were drugs. We start with ACE inhibitors, then beta blockers, then diuretics, then maybe other calcium channel blockers, and then cardiac resynchronization therapy, all along the ladder as the disease increases. Then there were further need for classification of heart failure, but it did not incorporate at all. From ACC classification and NYHA classification, as the mechanical circulatory support came into the picture, we went to the Intermax classification. Intermax classification was mainly for mechanical circulatory support, mechanical circulatory devices, which would assist which would classify when the patient should go for device therapy. So this is a comparison between them. And according to the classification of Intermax and NYHA, so was the treatment which is divided like heart failure population, find the cause, ACE inhibitors, beta blockers, aldosterone antagonists, ICD, etc., to be upgraded as the patient deteriorates. Then there was another, this was just the classification between ACC, NYHA, and Intermax classification. Intermax classification goes from 1 to 7, then 1 to 3 are really worse patient, and 4, 5, 6, 7 are stable patient. So this classification has its definition and has its ejection fraction percentages, because similarly, soon after that, there was a classification of heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. So there were 4 classifications in terms of left ventricular ejection fraction. In the management of acute heart failure, really left ventricular ejection fraction carries a role or not is debatable, but then this was a classification which mainly looks after the diastolic failure of the heart. Then according to the stage of ABCD and according to the risk factor, so was the treatment given for them. And again, the therapeutic goals for stage B, ABCD are being to treat them accordingly, according to the severity in terms of drugs has been given here in the therapy goals. We have very few drugs for heart failure, in fact. The ACE inhibitors and the ARNI product, the beta blockers, the mineralocorticoid receptor antagonists, ivermectin and digoxin or hydralazine or isosorbate dinetic. These are the few drugs available. Not much drugs are available in them. Then came up the 4 pillars of management of heart failure, which I'll cover later on. In this classification, then depending upon the cardiogenic shock, the working groups, they form a new classification called the cardiogenic shock trials, which were divided into A, B, C, D, E. They were into at-risk, beginning, classical, deteriorating, and extreme. This is now the final classification at the moment prevalent to classify a acute heart failure patient, and they have their own parameters, hemodynamic, laboratory values in the physical examination findings. And this is the total comparison of the various classifications of acute heart failure from the earliest group of acute myocardial infarction cardiogenic shock to size shock stage classification. How are they equivalent to each other in various respects has been demonstrated on this slide. Then according to the staging of the acute heart failure, the guidelines determine medical therapy. That these are the 4 pillars of the medical therapy for acute heart failure. One is the ACE inhibitor, second is the ARNI group, third is the beta blocker, and fourth is the ACE inhibitor and the ARNI group have been grouped together. Then the mineralocorticoid receptor antagonist, and then the SGL2 inhibitors. These are the 4 main drugs at the moment in prevalence for the treatment of acute heart failure, and they have things to go. They have their own indications and the contraindication and the doses and the potential side effects and clinical consideration. We have been using them quite commonly, and they have been working according to me. Other than these drugs, digoxin, I use it very frequently. Then I used even an Ayurvedic drug called Arjuna Rest. I use definitely iron therapies, zinc supplements, etc., which does help apart from these drugs. So this is that graph to show you the 4 pillars of management of acute heart failure, from stabilization to optimization. How much you can go to the maximally tolerated dose of the drug has to be determined by regular follow-ups. And other drugs, other than these 4 drugs, are these Vericiguat, the Digitalis, the CRT therapy, Ivabradine, and other hydrolyzine nitrates, ACE inhibitors, and ferric carboxy, maltose, etc. So, shifting the paradigm from the ICU management of an acute heart failure, people have been adding all these 4 pillars of acute heart failure in a stepwise manner. Some schools of thought start them on day 1 and then they gradually titrate the doses. So this is the pathway of admission of a patient of acute heart failure from hospital admission to day 3 of intravenous therapy and up to day 7 of oral therapy, and followed by 6 weeks of close monitoring. Females do much worse in acute heart failure management. They require a more close monitoring. Then these are the various types of diuretics which have been used at various levels, which can be given to a heart failure patient in combination to increase the fluid overload of the congestion part. And this is the recommendations, the classification of the level and the class of the effectiveness of various therapies of heart failure management: oxygen therapy, diuretics, inotrope, vasopressors, other drugs, and follow-up discharges. So this was guidelines directed medical therapy. Then acute heart failure and mechanical circulatory support. As I said, the acute heart failure sometimes goes very rapidly and does not give you time for the medical management to be effective, and the patient lands into a refractive shock. In such a score, then I would like to take you to a very interesting thing, which is done in every ICU, and we are not mindful about it. This is the inotrope score. Every ICU has a syringe pump, every sister labels a syringe pump, but in no ICU have found a sister talking about the drug in terms of microgram per kilogram per minute. They will talk in terms of ml per hour. So this concept has to come. The staff has to first learn about the concentration of the drug, then only they will know that they are reaching the dangerous level or not. Point number 1. Inotrope score of this strength has been given an arbitrary score by University of Michigan, where they have allocated that inotrope score of more than 20 is deleterious to the heart. At that point, you should stop thinking of medical management and you should start thinking of a mechanical treatment. But I find even in my ICU, I don't even raise an eyebrow when my inotrope score is crossing 40. And at other places, I find inotrope going to 200, and people are not mindful. They are just almost squeezing the body to like anything. If you are using such a high concentration of noradrenaline, adrenaline, and vasopressin, then they are doing more harm than good. So this concept of inotrope score has to be very clear with our physician population, and then to be transferred to our nursing population to get activated or to alarm the patient and the relative that we are now reaching the end point of medical management. So this I will just show the deleterious effect of norepinephrine and the sympathetic nervous system. As the dose keeps on increasing, it will cause LV hypertrophy, arrhythmias, and apoptosis. This is just to show you the microscopic picture of the myocyte with a normal cardiomyocyte, and if you give them a high dose of norepinephrine, the myocyte will become a clump of protoplasm. This is what happened to the myocyte in a very high doses, the chemical toxicity of now norepinephrine. So you are killing the muscles of the heart by increasing the strength of inotropes like anything. You have to be mindful. Therefore, in acute heart failure management, when chemical treatment does not cross more than 25% of effectiveness, then the concept of temporary mechanical circulatory support and permanent mechanical circulatory support has evolved. But in India, because of our economy, we are not able to do much, but it has been a long time and we are debating, and this issue is there, and slowly we are solving this issue. So if you are talking of inotropes and mechanical circulatory support, in this cascade of deterioration of myocardial infarction to cell death, this is the hypotension part and the systemic perfusion. This is what the mechanical circulatory support will address. Inotrope will address 20%, mechanical circulatory support will address 80%. You can see the population of cardiogenic shock is much more than the total population of cardiogenic myocardial infarction and acute coronary syndrome, which has been gradually increasing over the 20th century from 2004 to 2018 onwards. And all along the diagrams and the flow diagrams, the refractory cardiogenic shock has come along with the treatment of mechanical circulatory support as a very important component of the management of acute heart failure, when the patient deteriorates very fast. So in the SCAI classification, from stage C onwards, if the patient crosses the classical stage of cardiogenic shock, in SCAI classification, then impeller device, which is said to be definitely very cardioprotective, should be applied not at the stage E, but at the stage C. Because in refractory cardiogenic shock, the impeller would only mend the heart, will not mend the perfusion, the tissue perfusion. And this is where at the stage C, ECMO or other impeller devices, they need to be addressed to or attended to the patient if we want to salvage the myocardium. So these are the other components of application of mechanical circulatory support, which I will cover shortly. If they say the ISIS shock trial, IBP shock trial says the IBP is useless, then I would just raise the point that number of applications of IBP has been more than 60,000 all across the world, whereas the number of other mechanical circulatory devices had not been more than 3,000 all across the globe. So is IBP a useless thing? I strongly oppose the idea that IBP does not work. It works where it has to work, and it works for the given hours it has to work. When you take it to 1 month and then you say it has to address all the possible effects of peripheral circulation and the metabolic complications by IBP, then you are over expecting from IBP. But IBP does work, and you ask any cardiologist, you ask any cardiac surgeon, when everything fails, IBP works. So IBP is still a very good instrument, though the statistic may show something else. Now, if not IBP, what are the other temporary supports which are available for the an ailing heart? One, if there's an adequate oxygenation or no. If there's an adequate oxygenation, percutaneous and surgical devices. If the oxygenation is inadequate, means the pulmonary edema is there, then percutaneous and surgical devices. In percutaneous devices, IBP, impeller, tandem heart. And again, if the oxygenation is not adequate, then ECMO, tandem heart, and surgical methods. For temporary support, like high-risk procedure, electrical storm, VT, acute MI, cardiogenic shock, percutaneous valve replacement, you require a mechanical circulatory support for high-risk procedure, for bridge to recovery, for bridge to decision making. This is all the points where temporary support can take the patient to cure and complete healing if you apply the mechanical circulatory support in time. These are the various types of mechanical circulatory support: IBP, impeller, tandem heart, CentriMag, Abiomed, and ECMO. And these are the features of all these devices. These are the various comparison of all the various types of the devices applied for temporary percutaneous mechanical circulatory support to an acute heart failure. So over the time, if I talk about ECMO, because I have been using ECMO for the last 25 years now, and I feel the ECMO has gained a important position in managing a refractory cardiogenic shock. And what ECMO, impeller is expensive and VA ECMO is the cost, but these are all the pressure volume loops of heart failure around the heart, and if you have to combine them all together, so combined approach of using various type of mechanical circulatory support to address the heart and the lungs is helpful. So combined approach of chemical support and a mechanical support would address the patient much better. Thank you very much.
Thank you so much, sir. for the enlightening talk on heart failure. As definitely sir has mentioned, I have seen the use of IBP sir uses extensively, and we have prevented cardiorenal failure in many patients, including sudden arrest during procedures, high-risk procedures like CABG and PTCA. So definitely sir, point taken. And my one question sir is just an academic question sir. Does selenium have any role in heart failure management? Do we check it? Should we? It's a prognostic or a diagnostic for cardiomyopathy, sir?
See, I've got no scientific data, but literature says trace elements, particularly selenium and molybdenum, are one of the causes of etiology of heart failure, dilated cardiomyopathies. So therefore, they must be playing a big role. And specifically as a project to give selenium and molybdenum to patients, I have not tried, but I would definitely like to add if given a chance, and I would like to add them.
Thank you, sir. Thank you, sir. Yeah. So, audience, any questions? So, it was a very exhausting talk. Heart failure is a massive topic. To cover it within half an hour, only I think sir can do it. And it was extensively covered. All the points were extensively covered. Audience, any questions? Doctors? Physicians, cardiologists? Yes, sir.
What is the cost of ECMO initiation and continuation?
Sir, you can eat a food in a dhaba also in 100 rupees, and you can go to a 5-star and eat in 10,000 rupees also.
Yes.
So is ECMO. If
average cost, sir?
Average cost, if I say 9 out of 10 patients cannot afford ECMO and they are denied treatment because we don't want to reuse, then this is criminal. I openly say I reuse. It is much better than giving a chance for the patient to live rather than saying, no, my sterility and my guidelines are more important. So if I reuse, the cost of ECMO would be less than 1 lakh at initiation.
Okay,
and other things, if you are wanting to help the patient, the consultant charges, the bed charges are all one-time cost, or you can waive it off. Only the medicine charges and the laboratory charges, they are important. They also have got a cost price and a market price, which is a difference of, I would say, 4 times or 5 times. What you get a CBC done in your hospital may be costing 50 rupees, you may be charging the patient 200 rupees. So if you come down at the cost price of doing the investigation at your working cost, then I would say you can have an ECMO done in a patient, a 5-day ECMO done in a patient at a cost of nearly 2 lakhs.
So
but if the hospital also charges, the consultant also charges, and the price for ECMO charges, and then you want to use everything new, then the newspaper charges of ECMO is anything between 15 lakhs to 50 lakhs.
So every day also there will be a cost like 50,000 to 1 lakh.
You want to charge for the machine because the machine costs 80 lakhs.
Okay.
So therefore you want to have a rent for the machine.
Sure. So average cost should be like 2 to 5 lakhs for initiation?
You divide, once you get in patient, you divide at 3 days, 5 days, 7 days. You don't talk of 1 month. A respiratory ECMO would take you to anything not less than 2 weeks to 4 weeks to get a lung opened up. So therefore, the VV ECMO or a respiratory ECMO is costly because it goes over for a period of 15 days to 1 month. Whereas the cardiac ECMO, you have the answer in 3 days to 5 days. Okay. Is the heart gone or the heart is working? If the heart has to pick up, it will pick in 3 days. Okay. So VA ECMO is a very economical ECMO. You get the answers. Yes, the heart is picking up or not picking up. Sure. So a VA ECMO can be done very effectively with due respect to all the cost in, say, for a 5 days cost in 5 lakhs.
Okay, sure. And what is your experience, sir? You must have used the maximum number of ECMOs in the country. What is the survival rate of ECMO for a respiratory and a cardiac case?
The entire answer is time. If you come to me in time, perhaps I may give you 70% results.
Okay.
If you come to me in a multi-organ failure with no urine output, septic condition, totally fired up circulatory system, no peripheral perfusion, very high anotropes, then what do you expect?
Sure.
So otherwise, leave out this its and buts. The international registry called as the ELSO, Extra Corporate Life Support Organization USA, has got a registry data of more than 2.5 lakh cases across the globe, which they are very particular, and they have been divided into neonatal in children and adult segment into respiratory cardiac cases. There, the respiratory cases, success is between 60 to 70% in respiratory cases and 30 to 40% in cardiac cases.
Thank you, sir. Thank you.
Sir, I wanted to ask one question. So, when exactly we start thinking about exit options when a patient is on a VA ECMO?
Right. If you find futility, the moment, as I said, you get the answers, you find the patient is going into cardiac stunning or there's a left ventricular distension and the inotrope requirement is increasing in spite of putting the patient on ECMO, or the patient has already gone into multi-organ failure with sepsis with maybe high doses of antibiotics. So if you find that your desired effects are not taking place, as soon as you put the patient on ECMO, your inotrope has to go up, your oxygen requirement has to go out. So if they are not going out and they are not maintaining and they are not able to wean off from the oxygen FiO2 levels or coming down on inotropes, and the patient is not maintaining its own parameters, that is the time to you. This is a relative answer. You at what point of time you want to call off? You have to put the patient on ECMO. You feel he is not improving today, he may improve day after tomorrow. So a cardiac call, 7 days. A respiratory call, 1 month. In 7 days time, by third day onwards, you start getting the answer, is the patient coming up or going down? You give 4 more days the patient for a chance of survival. But by 7th day, your answers are very clear in front of you. Is the patient requiring additional mechanical circulatory support in terms of an Impella or in terms of an IBP device or in terms of the patient going on VVA ECMO or a respiratory ECMO in addition to a cardiac ECMO, the patient is going downhill, you can take a call.
And sir, if we have to consider a situation where things are not futile, but we are thinking of bridge to bridge, at what point we should prepare such relatives for bridge to bridge?
Of course. See, if you are thinking of a situation of bridge to bridge, you have to preserve the patient. So you have to dry the patient, you have to keep the patient infection free, you have to try to do CRRT and maintain the urine output. Then you are taking 100% efforts to make the patient optimum to receive an artificial heart or organ transplant. So for that matter, the aim is now not survival or death. The aim is life and transplant or this thing. So that period may be 1 month, because you will not get an organ very soon. And even if it is an artificial heart, the cost of the first degree, the highest class heart mate device is 70 lakhs, second order is 30 lakhs. So if you have to make an investment of 30, 50, 70 lakhs, you will have to have the patient in the best possible condition. Otherwise, putting an artificial device in an infected patient would not be a result. So that optimization may take 1 week, may take 1 month, but you will wait till the time your patient is infection free, patient is maintaining hemodynamics, patient is a minimum support, ready to wean off.
Thank you, sir.
Thank you, sir, for the enlightening talk. All are definitely blessed today to hear from you.
Sir deserves a special mention. So I would invite Dr. Deshpande sir to say a few words for sir. We are really, really indebted.
Friends, let me thanks Dr. Venkat Goel and Dr. Madhvi Goel for giving us opportunity. He has literally told me that you can have this hall and beautiful audio visual for a whole year. We are more than happy. So I was really happy. Friends, Riddhi Vinayak Multispeciality Hospital, I think it's a dream come true of a father and son. I can see what the son has done in this land, and I'm sure a day will come where we will have a Riddhi Vinayak Multispeciality Hospital along with a beautiful medical college. I wish him all the best for that. Thank you. एक आपके साथ कमेटी का फोटो राजू एक हमारे Friends, we are just probably we don't know whether he will be available to us, so we are taking one photo, group photo with him. Friends, next is we have Dr. Bura Swane as a moderator. I think we both in the Nalasopara East and West, almost 38 years before we started the hospital, when we used to have a lot of infarct patients. Forget about the ICU in this region. That time, mine was the first ICU on the East. Buraj is, I think, second on the Nalasopara West. And so many of our infarct patients, they had died in between the railway crossing. For hours together, the patient used to wait on the railway crossing when the gate will open. That was the time when we came here and started our practice. So let me have Dr. Bura Swane as a moderator, and he will introduce the speaker.
Thank you very much, Dr. Ravi, for kind information and kind words. Today we have the topic, Contemporary Acute Coronary Syndrome Management. What has changed and what matters? I remember 40 years back, when we used to sit in the ICU, the management was very simple. Just to start nitroglycerin drip, give aspirin, give tablet Dulcolex, and at the most Tribazole, and the matters over. But in last 40 years, it has changed tremendously from angioplasty to bypass surgery and complex angioplasties. And the word contemporary itself suggests that what has changed in over a period of last 50 years. And for that purpose, we have got here about the speaker, Dr. Rajeshwar Joshi. He has done the MBBS from the said GS Medical College, from the Grand Medical College, same as my college. He has done MD from the MMISR and DM Cardiology from BYL Topiola National Medical College, Nair Hospital. He is at present assistant professor in prestigious GS Medical College, Mumbai. And he has got a lot of interest in interventional cardiology, along with that, preventive cardiology. In that way, the risk management, also in the dilated cardiomyopathies and the valvular heart disease, he has got a great interest. So with this short introduction, I will ask Dr. Rajeshwar Joshi to start his acute coronary syndrome management.
Yeah, thank you, sir, for the introduction. And thank you, API Palghar chapter, for inviting me for this prestigious event which has been held. And I'll like to thank Dr. Jaiprakash Mishra. He is my second year DM cardiology resident who prepared the slides for me. So I didn't delete his name, I kept it the way it is. And I'll also... हाथ में ही दे दो ऐसे करो ना was trying to say something I didn't understand. I'm sorry for that. So we move ahead. So I'd like to thank Dr. Jaiprakash Mishra, who's my second year DM resident. And at the same time, I'll like to remind you all that I'm here on behalf of Dr. Suchit Mahale. And he is currently at Turkey and trying to learn TAVI and other mitral clips and other interventions. So he'll be back, I think, next year. So let's move ahead. So the topic which was given to me and like what the contemporary ACS guidelines or management strategies. So instead of going through or preparing my own strategies, I asked my resident Dr. Jaiprakash to just formulate a small little PPT in which can give take-home message on every slide. All right. So be focused. We'll go through it one by one. All right. So let me start with the class of recommendation and level of evidence. All right. So class of recommendation, whenever we say there are class 1, class 2 and class 3 recommendations. So class 2A and class 2B, you just have to remember these things. The class 1 is strongly recommended, whereas the benefit is much higher than the risk, and class 2A is moderate, where benefit is higher than the risk, and class 2B also benefit is either higher or equal to the risk, and class 3 is either benefit, there's no benefit or there is harm. All right. So with this in mind, we'll talk about each and everything what we go through. What is ACC or AHAR talking about in the year 2025? All right. So coming to the basics. All right. So this is the coronary artery, schematic diagram of it, and there is the atherosclerotic plaque, and when it ruptures, that is a time when, or ruptures or erosion take place, that is a time when we have a symptom of MI. I'll not get into the details of it because we have all studied that. So let's go ahead and what is non-STEMI or non-ST elevated acute coronary syndrome or ST elevated myocardial infarction. The ECG criteria are on board with you. Now for the non-STEMI, we say ST depression more than 0.5 millimeter in 2 contiguous leads and T inversion more than 1 millimeter in more than 2 contiguous leads with prominent R wave or R by S is more than 1. And STEMI, as we all know, ST elevations, जैसे हम ECG में देखते, we are quite scared about that. At least I was when I was doing my MBBS or MD. Now, after the guidelines, I'm like kind of okay with it. ST segment elevation more than 1 millimeter in more than 2 anatomically contiguous leads. Sometimes there is just a single lead which is showing ST elevations, so we don't have to worry about it much. We'll come to know like what do I have to do at that time. And V2 and V3, it has to be not considered, and it is more than 2 millimeter in men more than 40 years and more than 2.5 millimeter in men who are less than 40 years. And females get a special 25% off over here. They get, it has to be considered positive at 1.5 millimeter in women. All right. So, and posterior leads have to be taken in case there is ST depression in V2 and V3. So let's classify on the basis of the pathology. There is non-occlusive thrombus, we get ST depressions. So if the biomarkers are negative, it's an unstable angina. If the biomarkers are positive, it is NSTEMI. And if it is an occlusive thrombus, there is a ST elevation, we call it as a STEMI. All right. So what are the types of myocardial infarction? There is type 1, type 2, type 3, type 4, 5. And type 1 is the one which we know mostly. There is a plaque rupture, but there is also type 2, imbalance in myocardial oxygen supply and demand, in which if a patient is in a shock, let's say, because of any kind of shock, septic shock, let's say, and if there are ST changes or biomarkers are positive, that is type 2, because demand-supply mismatch is there. And type 3 is when there is cardiac death has already occurred, and we are thinking that it was because of cardiac, but the death was because of cardiac origin, and we do not have any proof. And then there is peri-PCI and peri-CABG. Now, there are some risk stratification tools for patients with ACS. You can easily get these tools on Medcal and just enter the data, and we'll get the risk stratification for each and every patient what we are looking at. Now, what is the in-hospital assessment of the patient with confirmed or suspected ACS? Now, first thing first, there has to be a focused history and physical examination. Without history, we go nowhere. Everything starts with the history and then the physical examination. If you think it is a suspected ACS, the class 1 recommendation is ECG has to happen within 10 minutes. And the class 1 recommendation is we have to get that cardiac troponin done. All right? So, whether after that, whether it is STEMI, if it is STEMI, then there is a different protocol which we'll see. But if it is not, then what is the class 1 recommendation? Remember that you have taken a good history, okay? The patient comes with a retrosternal chest pain which is radiating to the left arm. So we do serial ECG monitoring. That is again a class 1 recommendation. There is serial cardiac troponin monitoring. That's a class 1 recommendation. Just because the patient's 1 ECG is okay, that doesn't rule out your MI, all right? Now, based on these, we take a clinical decision pathway used to define the risk, which we saw the GRACE score and TIMI scores. So we can divide them according to the risk and take the further course of action, which we'll see on the next slides. And if it is yes, then we have to evaluate for reperfusion therapy. And how do we do that? We'll again see the recommendations. All right? Now, the management, if the patient comes after cardiac arrest, what do we do? Let's say he has return of spontaneous circulation. So first of all, we have to check the mental status, present of STEMI, prognostic feature, and what the guideline says. If the patient is awake and there is STEMI, we have to go for primary PCI. If the patient is either comatose or non-comatose, but there is STEMI and there are favorable prognostic factors, then we have to go for primary PCI. And the patient is comatose and there is STEMI and it is unfavorable, then we see that it is reasonable, but the recommendation becomes class 2B, all right? And the patient is comatose, there is no STEMI, and patient is hemodynamically stable. So that comatose patient is because of something else, so there is no benefit. It is class 3 recommendation. It's a harm to the patient. So the same thing is repeated again in a different fashion. Now, standard medical therapy for acute coronary syndrome. Now we talk about the oxygen therapy. Most of us, like when I was MBBS intern or during MD, whenever MI patient used to come, usko oxygen laga dete the. So now the class of recommendation for oxygenation of the patient is in a patient with ACS with confirmed hypoxia. So oxygen saturation has to be less than 90%. Then only we have to go for O2 supplementation, or else it's not required. More than 90% is recommended to improve the myocardial oxygen supply and decrease anginal symptoms. It has to be more than 90%. That's it. There's no benefit in case the patient of ACS and in a patient of ACS, the oxygen saturation is more than 90%. So routine administration of supplemental oxygen is not recommended. So what are the analgesic treatment? The patient of MI comes to us. What are the analgesic treatments which we are supposed to consider? We can give nitroglycerin, but suspected RV infarction, or if the systolic BP is less than 90, it is contraindicated. Now, IV nitroglycerin can be started, and then morphine and fentanyl, the doses are mentioned, and there are some consideration which have to be taken care of while giving these drugs, all right? So what about the antiplatelet therapy? Let's talk about the aspirin drug. So class of recommendation is 1, all right? In the patient with ACS, the initial loading dose of aspirin followed by daily low dose aspirin is recommended. That reduces death, and MACE. MACE is major adverse cardiovascular event. So what about P2Y12 inhibitors? Now here we see that even this has got a class of recommendation 1. So in patient with ACS, oral P2Y12 inhibitor should be administered in addition to aspirin. So in addition to aspirin, that's a word which has to be underlined. And in case the patient has a history of stroke or TIA, prasugrel causes, the class of recommendation is 3, it causes harm. So take a history. If the patient has TIA or stroke, prasugrel should not be administered. So let's see what are the oral P2Y12 inhibitors in hospital management of patient with non-STEMI. Okay. Undergoing PCI, prasugrel or ticagrelor is recommended to reduce MACE and stent thrombosis. Class 1A recommendation. In patient with NSTEMI who are managed without planned invasive evaluation, ticagrelor is recommended to reduce MACEs. In patient with NSTEMI, clopidogrel is recommended to reduce MACEs when prasugrel or ticagrelor is not available. So now in 2025, you can see that clopidogrel has taken the back seat. The first drug of choice has become ticagrelor. In case it is not available, then we have to shift over to clopidogrel. And we see class 2B recommendation if the patient is planned for invasive strategy with the timing of angiography anticipated to be more than 24 hours, then upstream treatment with clopidogrel or ticagrelor may be considered to reduce MACEs. All right. And now we talk about STEMI management. It's almost the same. So if the patient is willing for PPCI, then prasugrel or ticagrelor should be administered. With STEMI patient with primary PCI, clopidogrel is recommended to reduce MACEs if prasugrel or ticagrelor are not available. And in patient with STEMI managed with fibrinolytic therapy, clopidogrel is administered. So if you can look at the third box, if you thrombolize a patient, then clopidogrel has got class 1 recommendation. If the patient is undergoing PCI, then we have to give ticagrelor becomes a class 1 recommendation. All right. And these recommendations are based on a lot of research which they do. Okay, so these are the doses mentioned. So we all know about it: aspirin, clopidogrel, prasugrel, and ticagrelor. Loading doses as well as daily doses. So how to select your P2Y12 inhibitor? So in case of PCI and STEMI or STEMI, aspirin plus ticagrelor or prasugrel has got class 1 recommendation, and in everything except for fibrinolytic in STEMI, there is class 1 recommendation of aspirin and aspirin plus clopidogrel rather than ticagrelor. Okay, now we come to P2Y12 inhibitors, which we intravenously we give cangrelor or similar drugs. So among the patient, if loading dose is not given, then who have not received P2Y12 inhibitor, most of the patients who come to us, some loading dose is given outside, then only we have to consider about intravenous cangrelor. And intravenous cangrelor, because it has rapid and potent platelet inhibitory effect with restoration of platelet function occurring within 1 hour of drug discontinuation. So even if the patient is planned for CABG, okay, then we can start with cangrelor, and just before CABG we can stop cangrelor 1 hour before the surgery. Okay. Moving ahead. Now intravenous GP2B3A inhibitor in patient with ACS undergoing PCI with large thrombus burden. Now with no flow or slow flow situation, then only intravenous GP2B3A inhibitor is reasonable because it improves the procedural success, but not to be administered routinely due to lack of ischemic benefit and increased risk of bleeding. So GP2B3A has to be considered only in slow flow, no flow situations. So in situations where we generally start patients on GP2B3A inhibitors intravenously because he has got MI, that may cause more harm. And even in slow flow, no flow situation, it is class 2A recommendation, not class 1 recommendation. Now we talk about the parenteral anticoagulation. We are talking about heparin and related drugs. So there is class of recommendation 1, PCI not planned, coronary revascularization and PCI planned. So class 1 recommendation in non-STEMI ACS, intravenous UFH is useful to reduce ischemic event. And in patient with non-STEMI ACS in whom an early invasive approach is not anticipated, then enoxaparin or fondaparin can be used. So we can, for early invasive approach, unfractionated heparin has to be stopped like 5 to 6 hours before whenever you do invasive approach if you are taking, because the enoxaparin and fondaparin has got longer T-half. So coronary revascularization class of recommendation is 1 in patient with ACS undergoing coronary revascularization, either CABG or PCI in the same admission. Parenteral and anticoagulation should be continued until revascularization to reduce the ischemic event. So you understand the benefit of UFH. It is more than what we saw just now. The class of recommendation 2A for GP2B3A inhibitors, and it is class of recommendation is 1 for heparin, unfractionated heparin 5000 unit IV TDS, which we generally administer, or QID. In patient with ACS undergoing PCI, intravenous unfractionated heparin is useful to reduce ischemic event, and in patient of STEMI undergoing PCI, bivalirudin is useful as an alternative to UFH to reduce mortality and bleeding. You can use bivalirudin as an alternative that has got class 1 recommendation. And then there are class 2B recommendation for bivalirudin and intravenous enoxaparin for maybe reasonable alternative to UFH to reduce bleeding. There is harm if you see the last one. In patient with ACS, fondaparin should not be used to support PCI because of the risk of catheter thrombosis. So make sure that the patient who is planned for PCI doesn't receive fondaparin. So here we are, anticoagulation therapy treated with fibrinolytic therapy, plan of invasive approach or revascularization. If we have a plan for invasive approach, then we continue with parenteral anticoagulation till the duration of hospital stay or till revascularization. And if there is no plan, then we can continue with enoxaparin, that is class 1 recommendation. And over here it is unfractionated heparin. Now we talk about the lipid management, what the class of recommendation in acute coronary syndrome. So the class of recommendation 1 in patient with ACS, high intensity statin therapy is recommended to reduce the risk of MACEs. And class 1 recommendation again, if we see in the patient with ACS who is already maximally tolerated statin therapy with LDL more than 70, adding a non-statin lipid lowering agent is recommended to further reduce the risk of MACE. I remember somebody asking what are the levels which have to be reached after acute coronary syndrome. So here's the answer in 2025 guidelines. Then even after maximally tolerated dose of statin, if the LDL is more than 70, we have to start him on non-statin lipid lowering therapy like ezetimibe or inclisiran or bempedoic acid. Now in the patient with ACS who's already on maximally tolerated statin therapy with LDL of 55 to 69, we are going below 70 now, all right? Adding a non-statin lipid lowering agent is reasonable to reduce the MACE. Now even that has got a class 2A recommendation. You can go below 70, all right? So you can go up to 55. We can add ezetimibe. And in 2B recommendation in patient with ACS, the concurrent initiation of ezetimibe in combination with the maximally tolerated statin may be considered to reduce the risk of MACEs. So we can, right at the first go itself, we can start with ezetimibe. So in patient who are statin intolerant, so there is class 1 recommendation will go for, of course, non-statin lipid lowering therapy. So this is the same thing which has been mentioned in a different format. So just remember, after ACS patient comes to you, the lipid has to be, the LDL has to be less than 70. So beta blocker therapy, let's talk about beta blocker. So all the patient with MI, generally previously we used to think that patient with MI should not be started on beta blocker in an acute situation, but only few contraindications are there. If there is acute heart failure, there is low output state, PR interval is more than 0.24, second or third degree AV block or severe bradycardia, or there is an active bronchospasm, then only we have to avoid beta blockers, otherwise we have to start every patient on beta blocker with ACS. So the recommendation level for this is in high risk patient with ACS less than LVEF less than 40 hypertensive diabetes, STEMI with anterior location. Oh, this oral, so we have shifted from beta blocker to the ACE ARB, reduce all cause of mortality and MACEs. So EF less than 40 we have to start. In patient with EF less than 40 with heart failure symptom and diabetes, MRA is indicated to reduce all cause mortality and MACEs. In ACE symptoms who are not considered to be high risk, oral ACE ARB is reasonable to reduce the MACEs. So even if it is not high risk, we still get benefit. The class of recommendation is 2A to start the patient on ACE and ARBs. So the contraindications for fibrinolytic therapy in case of STEMI, we all know it. So intracranial hemorrhage or structural cerebrovascular lesion, non-malignant intracranial neoplasm. We have to take a brief history before we thrombolize the patient. So we have to first check ACS patient whether he is hemodynamically stable or not. If there is instability is present, there has to be emergency revascularization of the culprit vessel either by PCI or CABG. That will improve the survival. That is class 1 recommendation. Any hemodynamically unstable patient, we are not supposed to first stabilize the patient before we intervene. We have to intervene straight away. That is the class 1 recommendation. That will improve the outcome. And time of the symptom of onset, if it is less than 12 hours, then we have to think about whether the hospital transfer is required. If it is a PCI capable center, then the first medical contact, FMC to device activation time should be less than 90 minutes. And if the transfer is required, it has to be less than 120 minutes for the primary PCI to take place, or else we have to thrombolize the patient. So if the patient comes to us from 12 to 24 hours, the class 2A recommendation is primary PCI. Still, even after 12 hours, previously we used to think after 12 hours it is of no use, but now the recommendation says there is a benefit for patients who come even after 12 hours up to 24 hours. The class of recommendation is 2A, and there is one more class of recommendation, 2A for primary PCI is reasonable in patients who has got ongoing ischemia, severe heart failure or life-threatening arrhythmia. Even they have got benefit with primary PCI, even if they come after 24 hours. So primary PCI is not performed due to lack of benefit if there is no such thing present. If the patient is not having ischemia, severe heart failure, or life-threatening arrhythmia, after 24 hours, the primary PCI has got no role. Alright, the similar thing, it's almost the same what we saw earlier, but in a different fashion. So whether we can fibrinolyze the patient if contraindication is present, then we have to transfer to PCI capable center within, if it is more than 120 minutes away, then we have to fibrinolyze the patient. That is a class 1 indication. So if you can send the patient to a cath lab in 2 hours, that's good. Otherwise, we have to thrombolize. So what about CABG, urgent bypass surgery? So in patient with STEMI in whom PCI is not feasible or successful with a large area of myocardium at risk, emergency or urgent CABG surgery can be effective to improve the clinical outcome. That is class of recommendation is 2A, not 1. So there is still a benefit of urgent CABG in patient in which PCI is not feasible. So that's coronary angiography when it should be done after thrombolysis. So we can transfer the patient to PCI capable center immediately after fibrinolytic therapy. That is the class 1 indication. We thrombolize the patient, and since if the nearest cath lab is less than 2 hours away, then we have to thrombolize and send the patient after that. Suspected fail reperfusion, if we think the reperfusion has failed, then we have to do a rescue PCI, or else we can do angiography up till 24 hours. That is a class 1 recommendation. And clinical signs of failed reperfusion, there are ongoing ischemic symptoms. The ST depressions are more than 50%. ST segment elevation are persistent, more than 50%. The resolution is less than 50%. And there is hemodynamic or electrical instability. Now, there is a rationale for routine invasive or selective invasive approach is the same thing which has been written again. So let's see. Alrighty. So let's see the rationale and timing of routine invasive or selective invasive procedure. For unstable patient, there has to be immediate invasive strategy, less than 2 hours. And high risk patient, there has to be routine invasive. It can be done up till 24 hours. And for intermediate risk patient, the scores which we saw earlier, then the coronary angiography has to be done before the hospital discharge. And low risk patient, there is a class 1 recommendation again of routine invasive and selective invasive procedure and coronary angiography before the hospital discharge. And thank you. So the take home message is send the patient for PCI ASAP.
Any questions from the audience?
Thank you, everyone.
Hi, excellent talk, sir. So what are your key clinical factors which will decide about an invasive strategy in a non-STEMI and unstable angina?
So the clinical factors remain the same. It has to be angina, palpitation, dyspnea, or any arrhythmia. So if these are, or hemodynamical instability. So if these things are present, we have to go for primary PCI. That is the class 1 recommendation. I'm just talking about what ACC said.
Okay, right, thank
you. After the thrombolysis, when will you transfer for PCI? As earlier, you have to wait. Is there any advantage or disadvantage?
There is a disadvantage of waiting. The guidelines are very clear. If the cath lab is within 2 hours of your reach, you have to send the patient for primary PCI. And if it is more than 2 hours of your reach, then you have to send the patient after thrombolysis. But after thrombolysis, we have to send the patient. And if the symptoms or the STs do not settle more than 50%, as I talked about, then we have to go for rescue PCI, or we can do it in 24, we can do angiography in 24 hours. That might show revascularized infarct-related artery, so we don't have to go for intervention after that.
Lot of advances are occurring in telemedicine, and I think some Tamil Nadu and Himachal Pradesh have started doing home ECG. There are 2 or 4 equipments available, 2 from Indian and 2 from foreign companies. Would you like to comment on that? How is it?
So that would be a fantastic approach to things, because we'll have a baseline ECG when the patient comes to the clinic or the hospital. So we can always, as we saw the flow chart, that if you strongly suspect that the patient is having an acute coronary syndrome, then class 1 recommendation is to do the ECG again, even if the first ECG is normal. So if we get the first ECG, that would be the second ECG which you take at the hospital, and that would be amazing, sir. And of course, earlier diagnosis will always be helpful in cases if there is ST elevated or non-ST elevated MI, we can intervene faster.
So about the low ejection fraction cases in which we do PCI, over a period of time, how frequently should we do a 2D echo? Is there a chance of regaining the lost ejection fraction in such patients? And how many cases we have encountered?
There is I don't know, I'm going against my fraternity if I say the truth, but once the EF is on the lower side, you should first get the viability scan done. If the myocardium is non-viable, there is no point in getting a PCI done. That is what we follow at KEM. So, sir, ऐसे ही बंद कर देंगे PCI तो फिर तो क्या?
What percent of ejection fraction you are talking about?
It's not about the ejection fraction. It is about RWMA. If RWMA is present for quite some time in a particular area of myocardium which is supplied by, we can of course delineate the artery which it is supplying. So we can get a viability scan for that. And it's not basically RWMA. Even if it is 50%, we can get a viability scan done. It's about the history. All right, thank you. And I'll like you to read it again because I know it was very short span of time. I just brushed through everything. Just it's going to help everyone out. And Deshpande sir has got the PPT. He might just forward it to you.
Yes, that's what I was going to request you, sir, because some things are definitely age-old concepts that we are still following, but new things keep coming up, cropping up. So if you can share the slides with everyone, at least the salient features with all the physicians, we will be obliged.
It's just 38 pages, and we might just practice something else, but we should know what is the recommendation. We might practice whatever we want to. Even I do the same. So. Thank you.
Thank you so much, sir. Thank you for coming all the way and filling in for the last moment. Thank you. Sane, sir. With this, we come to the last part of our session, the panel discussion, which we all are waiting for. So I would like to call on stage Dr. Rajiv Sharma sir, who is going to lead this session. So in this panel discussion, the first speaker is Dr. Ashish Mishra. The topic is understanding refractory heart failure, its definition, pathophysiology and classification, and our moderator is Dr. Preetam Mahire. Is Dr. Preetam Mahire here? Dr. Ahire has done his MD from KM Hospital and is a consultant physician at Cure and Care Clinic, Vasai, practicing since 8 years, and he has multiple publications in national and international journals. So please introduce Dr. Ashish Mishra.
Thank you, Dr. Anamika, for your kind introduction. So Dr. Ashish Mishra has done his DM cardiology from BJ Government Medical College and UN Mehta Institute from Ahmedabad. He was an assistant professor in cardiology in BJ Medical College from 2020 to 2022. He is an interventional cardiologist with expertise, training and experience in diagnostic and therapeutic cardiac interventions, clinical cardiology and academic teaching. He is proficient in complex coronary and peripheral interventions, intravascular imaging, acute interventions for DVT, massive pulmonary embolism and heart failure management. He is currently attached with Wokhart Hospital as a consultant interventional cardiologist and has authored and co-authored many multiple papers in reputed journals. He is a reviewer for JACC journals and a regular speaker at Forum on Heart Failure, ACS, Lipidology, Hypertension and NOAC. So, Dr. Ashish, I'll hand over the session to you.
Thanks for the kind introduction. Thanks to the organizers for providing this opportunity. Respected dignitaries and seniors and my colleagues. So I'll take a lead from here. Can you share the slides? Yeah. So basically, we'll be discussing a few step-by-step, basically refractory heart failure. So the topic which has been given to me is understanding refractory heart failure, the definition, pathophysiology and classification. So as we know, in fact, Dr. Venkat sir also in fact had a overview of this condition. Maybe that there are some overlapping terms also and we'll be discussing these terminologies. So we know that the global burden of heart failure is ever increasing. The allied economic and the clinical impact also remains high because 50% readmission rate as early as within 6 months. Also about 2 to 3% of the total healthcare expenditure amounts to the management for this heart failure patients. Also the clinical relevance which turns up here is this, it represents failure of compensatory mechanisms and exhaustion of medical options as well. It requires specialized management, often bridging to LVAD, transplant or maybe palliation. So this is one of the key slides which I wanted to highlight for our audience. So the various definition and terminology which are allied with maybe advanced heart failure, what is refractory heart failure and what is end-stage heart failure. So advanced heart failure again is a stage D, severe recurrent symptoms. Usually the patients are in NYHA class 3 to 4. The response is partial or suboptimal. Reversibility, yes, is possible. There are some cases where we can have this reversible heart failure, particularly like the peripartum cardiomyopathy, pulmonary embolism with a massive pulmonary embolism. Again, those patients with acute QRVB interval MI, prompt intervention again would be very helpful in this case. So again, the prognosis is variable. Then we have a continuum which is a refractory heart failure, which is an extension of advanced heart failure. Patients are basically the symptoms are persistent. Response to guideline directed medical therapy is almost negligible. Yes, this patient's the reversibility is true, but they should be bridged in time as Dr. Venkat discussed. Also, the therapeutic goal are usually supporting the hemodynamic circulation and bridge-to-bridge care. Again, the prognosis remains poor if the care process is dismal. And end-stage heart failure patients, these are burnt-out patients, maybe that they are symptomatic at rest, they are inotrope dependent, device dependent, maybe futility of care is also setting in, and they are basically for palliative care. So basically what I would like to highlight is the conceptual flow. It starts with the chronic heart failure, maybe advanced heart failure, then refractory heart failure and end-stage heart failure. We have also an entity of acute heart failure, like as I described, the three commonest condition is acute interval MI or maybe leading to low ejection fraction, maybe massive pulmonary DVT. Then we have Takotsubo's cardiomyopathy or myocarditis, which leads to acute heart failure, which may turn up into advanced heart failure and maybe also mortality if not assisted in steps. So each step reflects loss of therapeutic responsiveness, worsening hemodynamics, also progressive end organ involvement, and transition from disease modifying to palliative goals. So this is basically overview of advanced heart failure. It is a subset of heart failure patients with severe and persistent symptoms. Usually they are NYHA 4 or advanced 3. Despite optimal guideline directed medical therapy, even maybe such patients may be on device therapy as well, like IVP, accompanied by objective evidence of severe cardiac dysfunction and end organ involvement. The AHA-ACC Society basically utilizes definition interchangeably. Basically, they classify subjects with heart failure from stage A to D. Stage D and advanced heart failure are used interchangeably in the relevant documents of its clinical recommendation, which also includes end-stage and refractory heart failure terminologies. So this is the definition which comes from the ESC Society, where the pertinent criteria have to be fulfilled before labeling a patient with having a advanced heart failure. So basically, function defined by ejection fraction less than 30%. It can be, the LV may be normal, but there can be involvement of isolated RV failure as well, which can be even pertinent in massive pulmonary DVT. Again, valvular inoperable cases, grown-up adults with congenital anomalies, all this into action. And also we should have raised NT-proBNP levels. There should be evidence of systemic or pulmonary venous congestion. And in fact, those patients who are for advanced care or maybe they're for bridge-to-bridge care, we should have a objective evaluation with peak VO2 levels or maybe at least 6-minute walk test. If this is less than 300 meter, again this patients classify as advanced heart failure. So refractory heart failure, as I discussed, it is a continuum of advanced heart failure. The patient may be non-responsive despite the GDMT devices and intervention and needs aggressive care, maybe advanced hemodynamic support or bridge to transplant. End stage heart failure is a terminal phase. Again, not much can be done, and the goal of care altogether remains palliative. So this is a slide which was discussed by Venkat sir as well. So in fact, we have variation in definition, but there is a alignment onto the process that the patient should be symptomatic. They should be on optimal guideline-directed medical therapy and yet symptomatic NYHA class 3 or 4, having recurrent hospitalization, and there should be severe functional impairment as well as end organ involvement. So in fact, there are some variations with the American Society and the European Society, but the key overlap is that they should be symptomatic on guideline-directed medical therapy with functional impairment. So these are the frequent or commonly encountered etiologies what we see. Usually to our practice, in fact, the coronary artery disease takes a heavy toll. Some of the times we deal with massive pulmonary embolism, maybe complicated peripartum cardiomyopathy, maybe myocarditis, maybe septic cardiomyopathy. So all these patients usually have a bad ICU outcomes if not assisted well in time. And usually the precipitators, if the patient has underlying pathophysiology and there are other precipitators like anemia, maybe arrhythmias, fluid overload, maybe uncorrected underlying endocrine disorders, maybe sleep apnea, all this add on to the burden and give a dismal prognosis. So going out to the top 10 causes of heart failure among the Asians, if we see there is a ischemic heart disease, a progressive hypertensive heart failure, again chronic obstructive pulmonary disease which leads to RV failure, the other cardiomyopathies, again in our part rheumatic heart disease leading to a significant chunk of valvular heart disease. We have non-rheumatic valvular heart disease, alcoholic cardiomyopathy quite frequent in our part, again congenital heart anomalies which have been not repaired in time, and myocarditis. So again, pathophysiology at goes is basically a dysregulated mechanism. It is a neurohormonal activation, cardiac remodeling, ongoing inflammatory stress and oxidative stress. So basically, as sir has pointed out very well, so we have a class which goes from ACC class, which goes from stage A to B to C and D. So usually these patients are in stage D. NYHA classification wise, they fit into, as per the definition, they are advanced NYHA class 3 or 4, and we have a specific classification for such patients when they are being contemplated for device therapy. When they are, as we can see, the profile 7, they are maybe at a better part as compared to the profile 1, and they are listed for heart transplant or maybe eligible for escalated support devices based on this classification. So profile 7 is basically advanced NYHA class 3 symptoms. Profile 6 is exertion limited, they are walking wounded, they come in and out of OPD, frequent ER visits for IV diuretics. Again, stage 5 basically on hospice care, exertion causes basically exertion intolerant, they are bed bound, house bound. Profile 4 are basically frequent flyers who have resting symptoms, they have frequent hospitalizations as well. Profile 3 and 2 are inotrope dependent, they are usually get a clinical endpoint, and again profile 1 are basically those patients who have critical cardiogenic shock, crashing, burning, having the worst prognosis. So basically, as we see, we have stages of heart failure as per the ACC-AHA, then we have a functional classification as per the NYHA, and we have an advanced heart failure profiles as per the Intermax, which help in management of these patients. Also to highlight, in fact, what I would like to highlight at this point is, although a severely reduced LV ejection fraction is common in such group of patients, preserved, maybe LV ejection fraction, RV ejection fractions may be normal. It may be the only severe PH and atrial cardiomyopathy. Again, for those patients with maybe constrictive pericarditis, a thick shell of pericardium, again such patients continue to have heart failure symptoms. The pathology is at the pericardium and the LV ejection fractions are preserved. Only those such subjects who are undiagnosed, untreated, they land up with progressive LV, basically the EF goes down. Even those patients who have isolated RV involvement, the LV ejection fraction goes down over a period of time, which is called due to Birmingham effect because of the IVS involvement. And again, this classification again is important, particularly for those patients with acute myocardial infarction, the SKY classification, where what we see is that the patient who we have to identify those patients who are at risk, who are at the beginning of cardiogenic shock, classical, the stage C, which we see are in patients in ICU, basically inotropes going up. Stage D, where the organ involvement is there, again we have physical, we have points for as per the physical examination, lab values, ABGA, and the creatinine lactate levels, and also the invasive hemodynamics in such patient. And basically stage E is those patients who are crashing, burning, again at the end point of clinical care. So what are the clinical symptoms for patients with advanced heart failure? Usually they are symptomatic at rest. Usually about more than 90% will be in stage, will have NYHA class 4. Most of them will declare symptom of orthopnea, PND or fatigue. They may also have cardiac cachexia. They have JVP elevated. We can hear S3 gallop. Maybe there can be peripheral edema. We can see pulses alternance also. Again, from the lab point of view, we can see such patients in their fluid overload, basically hypervolemic hyponatremia. AntiproBNP levels are on higher side. Imaging will also give a clue to the diagnosis. Maybe we are dealing with only the myocardial pathology or a valvular pathology, or maybe some pulmonary embolism. Again, a cardiac MRI for such patients is important if we are able to. So whether such patient will be, it can also predict if they have fibrosis, whether they will be a candidate for a heart transplant ahead. Again, invasive hemodynamics also have a role when they are being contemplated for hemodynamic support devices and transplant. So usually this is the natural history of patients with advanced heart failure. Usually the onset of heart failure with some medical management, the quality of life improves. It is basically intermixed with some arrhythmias which can lead to sudden cardiac death also. And then again recurrent heart failures which cause decompensation and advancement to heart failures, where at this point of time we are thinking about hemodynamic support devices, advanced medical therapy, maybe ICU based therapy. They are on inotropes, and again for those patients who still are not responders, they are progressing to refractory heart failure, again a bridge to bridge or a bridge to recovery care has to be given. So overall, in fact, the natural history is not as dismal with this group of patients. Median survival post diagnosis of advanced heart failure ranges about 12 to 18 months. Usually ischemic cardiomyopathy patient, elderly patients who have persistent hyponatremia, EGFR or organ involvement with renal or hepatic is there with EGFR less than 45. Usually they don't do well. Patients who are even at the point of discharge have elevated NT-proBNP levels, or they have persistent elevated NT-proBNP levels. They also have a poor prognosis. Again, those with Intermac class 1, they have in-hospital mortality of more than 50% with or without MCS devices. So for prognostication, again, the various studies have utilized various risk models. In fact, the most validated model is the Seattle heart failure model, which integrates about 20 variables. We also have a magic score which is coming up, which predicts about 1 to 3 year mortality when the patients are in early part of advanced heart failure. So again, all these scores do tell us about that, whether we should be only managing with guideline directed medical therapy, or maybe we should be advancing them to a designated care for heart failure, advanced heart failure. So also there are key prognostic indicators when these patients are being contemplated for even heart transplant, particularly the peak VO2 and 6-minute walk test. So this is the key slide which I'll say as a key take home message. So how do we identify such patients in our practice who are heading to advanced heart failure or who have existing advanced heart failure? Are those patients who have a background of heart failure, they need inotropes time after again, their class is NYHA advanced class 3 or 4, repeated admissions, they have end organ involvement, worsening renal or liver profile, ejection fraction has dropped to below 20%, maybe they having repeated arrhythmias in the form of atrial arrhythmias, ventricular arrhythmias, also that the escalated need of diuretics, maybe intravenous diuretics, infusions for the peripheral edema or the failure symptoms, also when they develop hypertensive symptoms or low cardiac output symptoms, and basically non-responders to the existing guideline directed medical therapy. So this is basically a mnemonic which has been promulgated by the ACC-AHA Society, which is basically comes as I need help, and we should know all these factors. So as we know, in fact, advanced heart failure is a multidisciplinary team management, and again HF specialists, cardiac surgeons, and patient, and a thorough discussion with patient and their families for the goal of care is quite important. So the key to take home message from here, I would say that advanced heart failure is a progressive clinical syndrome, rising global prevalence of heart failure with shift in particularly the demographic is quite pertinent at this point of time, even in South Asians, because we see more overall CV morbidity and mortality as of now also remains high. Early recognition and timely referral to basically advanced HF care institutes is quite vital, and in fact for such patients I need help that mnemonic would help out to figure out such patients from our community which are having that non-responder state, or they are progressing to advanced heart failure. That would do good for our patients. Thank you.
Thank you, Dr. Ashish, for brushing up our knowledge. One question from my side. Sir, can peritoneal dialysis play a more significant role in managing volume overload in diuretic resistant heart failure patients?
So usually the studies are not with peritoneal dialysis, they have been studied with ultrafiltration for those patients who are hemodynamically compromised. So peritoneal dialysis is not one thing which will be easily advocated for such patients, because they have multiple, the pathophysiology lies at the cardiac axis, and we have to address cardiorenal axis as well. So in such patients, if at all to help is what we can offer is ultrafiltration. I think that is a part of care for such patients, but definitely we should be targeting for hemodynamic support. It can be escalated inotropes and then bridging them to the hemodynamic support devices. So I think management of only fluid is one of the part which will give symptomatic relief, but will not drive out that patient from that heart failure state, or will not add to the prognosis or the quality of life.
Yeah. So one question from my side. We see many patients who have BP which is around 90, 60, and they are in our ICU. On noradrenaline, they are maintaining a BP of around, 95, 100, and the urine output is 50 to 60 ml per hour. And the relatives are insisting, ICU se bahar le lo. What is your take on midodrine as an oral drug in such a situation, and you stop NORAD and you shift the patient?
So yes, so that therapy I have been utilizing for most of our patients. I have good experience with, since at Wokhad also, that I have been able to manage some of the patients with chemotherapy-induced cardiotoxicity, and even there is a now concept now those patients who are still non-responders to midodrine. It is one of the oral medication which can be used so that the inotrope goes off, the blood pressure, systemic blood pressure is maintained, or the MAPs are maintained, and we can have good urine output. But then if such patients are not responsive to midodrine, in fact we should have a thorough discussion that this patient fit in that I need help type of mnemonic, and we should be discussing for the escalated care. Such patient can be on hospice care also. I have 3 patients who are on hospice care with a PICC line and a milrinone infusion, so which is one of the designated care therapy. But this is for those who have a reversible element. So usually cardiotoxicity related, chemotherapy cardiotoxicity, peripartum cardiomyopathy, or maybe those patients who have a bad RV post. Otherwise, they have to be like a bridge to bridge. They have to be transferred to a heart failure designated hospitals. We usually send our patients to HN Reliance for combined heart lung, or like the heart transplants patients. So they have to be picked up well. Maybe we have options to bridge over, like oral tablets for who are in the early part, like the Intermac, I would say 5, 6 here. And for those patients who are still not doing well, they are showing signs of malperfusion, maybe organs are getting involved. For such patient, maybe intravenous inotropes or maybe milrinone with a PICC line, which will give some bridging time and send them to higher centers for evaluation, and maybe to see feasibility for maybe transplant or maybe escalated support devices.
Any questions from audience?
That was quite a crisp presentation. We have more to come, so please, I think we continue with the next presentation and then we wind. So our next topic is management strategies in refractory heart failure. It's about the medical and surgical therapies both. And we have a speaker, Dr. Pranil Gangude, and the moderator is Dr. Jain Yadav sir. Talking about Dr. Jain Yadav sir, he is a very senior consultant practicing more than 30 years. He is attached to SL Raheja Hospital, Bhakti Vedant, Wokhad Hospital, and he has his own Hindu diabetes specialty and diabetic foot care hospital. He has done multiple studies and publications and clinical trials. I would like to request sir to introduce Dr. Gangude.
Hello. Good afternoon to everyone. Firstly, I must thank Anamika for inviting me here and chair the session. Today's already we have discussed all the spectrum of cardiac diseases. That's why it is called conclave of cardiovascular conclave. We get all the information from stalwart and the people who are practicing more than 30 years. Initially, I have seen Dr. Rajiv Bhagwat is given talk on the complicated angioplasties. Harminder Singh said on lipid profile. Dr. Venkat Goyal talk on acute coronary syndrome. Now Dr. Joshi has given all the academics about the heart failure and everything. Ashish is already discussed first part of refractory cardiac failure. That is the end stage heart disease. Now, the topic is going to discuss Dr. Pranil Bhalchandra Gangude. He is basically going to talk the second part of refractory cardiac failure. He did his MBBS from BJ Medical College, Pune, DNB Cardiology, Lokmanya Tilak, LTMG. He is a consultant cardiology Guru Krupa Specialty Hospital in Mira Road. Adhikari Lifeline Hospital, Boisar, work as a reviewer of the Journal of Indian College of Cardiology. Selected for a national award for Torrent Young Scholar Award and work as a second operator in TAVR program, done 4 procedures till now. With this his introduction, I will ask Dr. Pranil to continue his speak. Thank you.
Thank you, sir. First of all, I will thank you, Dr. Venkat Goyal, sir, for inviting me here, and all the members of Association of Physicians of Palghar. Thank you very much. So today I am going to talk about management of advanced heart failure actually. कहाँ पे रखा है? स्क्रीन पे ढोले? उसमें आगे कंटिन्यू उसमें नहीं है, उसमें नहीं है। मैं आपको व्हाट्सएप किया था अभी सुबह। उसके अंदर नहीं, इसके एक मिनट, इसमें हाँ और इसने डाला ही नहीं, नहीं डाला नहीं होगा। व्हाट्सएप जो किया है दिस वन साइन करेक्ट। हाँ Maximize screen. Okay, finally. So actually I was supposed to talk on a refractory heart failure, but as Ashish have explained, the advanced heart failure and refractory heart failure are not interchangeable terms. So refractory can be many vast spectrum of patients, even from a mildly reduced fraction or sometimes even preserved ejection fraction to a reduced ejection fraction. So I will cover only heart failure and what is new. I will try to show something new. So as sir, most of the part sir has made us easy. These are stages. So as everybody knows, stage A is at risk, B is pre-heart failure, stage C is symptomatic heart failure, and stage is advanced heart failure. So basically we are talking about stage C, advanced stage C and stage D. So this is the trajectory of a stage C heart failure, in which the most of the heart failures are, some are newly diagnosed or some having pre-existing history of heart failure. We called it as acute on chronic precipitation. Then some of the patients, the trajectory will be either there would be a resolution of symptoms, that is improvement, either there will be persistence of symptoms, or there would be a worsening. So according to ejection fraction, we have divided it into a LV ejection fraction. If it is more than 50, we called it as heart failure preserved ejection fraction. If it is mid-range, between 40 to 49, we called it as a mid-range ejection fraction, or if it is less than 40, we called it as reduced ejection fraction. So in India, how the heart failure is different from rest of the world. So basically, as we all know, India, we are the second most, or I think it's on paper, we must be the largest population in the world as a single country. So aging population is one factor. Second is young, as we all know, from the young age, we are getting a coronary artery disease. Third is there is epidemic of diabetes and hypertension. Fourth, maybe infectious diseases are not that much common in the rest of the world. So rheumatic heart disease, that is structural heart diseases, are very common in India, and because of that, that contributes to a majority of patients of heart failure. So coronary artery disease and diabetes, hypertension, and rheumatic heart disease. These are the main contributors to the population of heart failure. So this is a graphic presentation. As you can see, how the heart failure starts at an early phase, then what is the course. And as you can see, the trajectory checkpoint, from there where the patient goes decides the outcome. Means if it is worsened, if it is responding to a treatment and it is improved gradually, or if it is initially on the treatment and on there it has a worsen because of some precipitating cause. Just Ashish has said that there are certain causes which precipitate an acute heart failure even with a normal EF, such as massive pulmonary embolism, it could be myocarditis, it could be acute coronary syndromes. So depending on that, how the patient is responding to a treatment or not decides the course. So how will you assess the patient? As Ashish already described, first is their history, ECG, lab investigation. We all know BNPs. Then there is TE, transesophageal as well as transthoracicocardiography is there. And depending on that ejection fraction, we have divided these patients. Unfortunately, in our mind, we say that refractory heart failure means, again, same thing. Means it's not restricted to one particular group of patients. It can be divided amongst all three. So this is a simple slide, but explaining most of the things. So as we all know, there are wet patients, there are dry patients. So diuretics always help act as a primary modalities of treatment. So that includes both loop diuretics as well as MRAs. Then second most important factor which we miss is the underlying risk factors. So many of the patients with preserved ejection fraction, hypertension is the most common cause. So uncontrolled hypertension, it could be an underlying coronary artery disease. Morbid obesity was not known to Indians. In the last few decades, we are facing the problem. We are getting obesity at a young age, childhood obesity is common, and because of that, obstructive sleep apnea. The terminology was introduced almost 10 to 20 years back. Even in Mumbai, I have heard it after I completed my MD. So people are talking right now about the obstructive sleep apnea, and the BiPAP therapy, that really plays very well. Effectively, the obstructive sleep apnea is causing uncontrolled hypertension, and uncontrolled hypertension gives majority of patients with heart failure with preserved ejection fraction, which are resistant to treat. Then third is the other associated comorbidities such as anemia, then patients who have renal dysfunctions, patients who have lung dysfunctions like COPDs or ILDs, patients with other medical illnesses such as depression or even diabetes. So all this is a what you can say comorbidities contribute a majority group of patients who are not responding to a regular treatment. Third is the neurohormonal things. As we all know, the majority of patients of heart failure, we treat ACEs, ARBs. ACE, ARBs, beta blockers, they contribute the heart failure treatment, and they basically act on sympathetic nervous system and your RAS. So class 1 and class 2 indications. So as we can see, stage A patients who had hypertension, as I told you, optimal control of BP is must. Second, nowadays we have added SGLT2 inhibitors, optimal management of CVD. The CVD contains all the things. It could be coronary artery disease, peripheral vascular diseases, and cerebrovascular diseases as well. The multidisciplinary approach, as we have talked earlier, helps to classify the patients properly, treat them according to the faculty. Means patients who have renal dysfunctions can have uncontrolled hypertension, and because of that they might land up into an repeated heart failure. Patients who had respiratory illnesses such as ILDs, COPDs, chronic smokers, end-stage lung diseases, or even liver diseases I have seen. Because of that, that puts a toll on the heart itself. So treating only a heart will not help unless you treat the underlying pathophysiology. Then as Ashish have told, there are certain diseases which are genetically affected like HOCM and everything. For that you have to do a genetic screening, even hyperlipidemia. Dyslipidemia is one of the factors which gives rise to coronary artery disease, and that gives rise to a heart failure effectively. So BNP, as I have told, BNP and ANP, they have been used as a classifying the patients and monitoring their treatment. ACEs, ARBs, beta blocker. The another thing is the patients who have less ejection fraction by ACCHA, ICDs, these are basically we call it as a pacing therapies, ICDs, CRTDs. These are the newer therapies which helps to control the symptoms, or even sometimes they help to improve ejection fraction. In patients who have ECG abnormalities such as wide QRS complexes, they help to improve the EF as well as they reduces the mortality, sudden cardiac death basically. Okay. So what are the changes? So as we all know, ARNI, a favorite drug. Patients who have less than 40% ejection fraction, they have been recommended class 1 by ACC-AHA. But in a clinical practice, as you can see, many of the patients who have coronary artery disease, even after they have improved ejection fraction, ARNI has been helped in the remodeling, reversing remodeling, reducing the rate of hospitalization in most of the patients. And along with ARNI, there are, as I said, improved glycemic control like SGLT2 inhibitors, they also help. Then other therapies are the anticoagulation that would be taken care by Dr. Rajiv afterwards. The newer things such as sarcoidosis and amyloidosis, these are the newer, what you can say, storage disorders. Tafamidis is a newer medicine which helps to improve survival in patients with amyloidosis. Then as I talked, resynchronization therapies, that includes our CRTD, CRTP and CRTD. So bundle his spacing is a newer thing nowadays. Patients who have wide QRS LBV basically, and EF less than 35%, and which are not responding to a oral medication, optimal medical treatment, they are the contenders. ICD help in those patients who had a history of arrhythmias, that mostly a ventricular arrhythmias, and in those patients, sudden cardiac death is prevented with an ICD is a class 1 recommendation. Structural heart diseases, patients of most with a reduced ejection fraction, most of the time they have a LV dilatation or LA dilatation, or even patients with rheumatic heart disease who have a mitral regurgitation. As we all know, MR begets MR. Over a period of time, just because the effective regurgitant orifice area of MR is more than 0.3 centimeter, they are landing into a pulmonary edema. Even with a normal, what you can say, maximum medical treatment, they fail to respond to treatment. In those patients, mitra clip nowadays is a what you can say structural procedure which helps to control the symptoms very effectively. Third thing is electrophysiological study and ablation. That shown a very good result in patients who have paroxysmal or persistent atrial fibrillation. And last thing is the end stage patients. As Venkat sir has already told you, LVADs, there are multiple models. It contains ECMO, it contains Impella, it contains tandem heart, everything. And depending upon the intermax level, we have to classify and treat them accordingly. So this is a new thing. So as I have told, multidisciplinary approach. Means though we talked about send the patient for heart transplant, and everybody knows that how many centers, dedicated centers are there. Even sir have told you ECMO or Impella. The cost effectiveness depends upon so many things. So many a times just treating the rest of the things, what you can say surroundings, that contains disclosure consultation, discharge test leaks, telemonitoring as we have already discussed. Rehabilitation programs works very well in most of the patients who are frequent, means who are chronic heart failure. They are stabilized with a proper rehabilitation programs and reduces the rate of hospitalization. Then NT-proBNP guided therapy, proper treatment titration, up titration or down titration depending upon the patient response is also important. And I have told you multidisciplinary approach contains multi-faculty approach. Depending upon patient's underlying pathophysiology of the disease, we should treat the disease itself, and automatically it will be reflected in your heart failure things. So as I told you, there are other multiple things. Sleep apnea. Obstructive sleep apnea is one of the major thing which was underrated or even neglected, I would say, because that contributes to most of the patients, even a younger populations whose hypertension is missed, and it can be treated even without medications if you lose a weight, or you can use a BiPAP therapy. Influenza vaccination, patients who have underlying lung diseases, if they are vaccinated, that will reduce their respiratory illnesses and effectively put a less toll on your heart. Iron deficiency anemia is very common in India. It can be structural things such as pure vegetarian peoples, we have B12 deficiency, which is very common. Pernicious anemias are common, or even some blood losing type of thing. In females, it can be menorrhagia. In males, it can be piles or some other diseases which precipitates the heart failure repeatedly. Worsening renal failure, as I have told you, RAS activation, which is the major thing. So whatever our ARNIs, our ARBs, ACs, they are all acting on RAS. But basically the RAS is controlled by the renal health. So patients who have diabetes mellitus, patients who have hypertension or even amyloidosis or other storage disorder, with a deranged renal function, progressively they becomes the candidate for heart failure. And treating the underlying disorder will help to reduce the hospitalization in those patients. Oh, this is a new thing. Patients who have already hospitalized, many a times it becomes difficult to modify their course in hospitalization. So the biomarkers, as I have told you, BNP and NT-proBNP and BNP will help us to decide whether what is the patient's future trajectory in hospitalization. The same things, sacubitril valsartan, tafamidis I have told about amyloidosis. Anticoagulants helps to reduce the further events. Anticoagulants are helpful in those patients with a heart failure and with dilated heart, means LV dilated patients who have recurrent atrial fibrillation. in those patients, it will reduce the rate of CVDs. Then there are short-term goals and mid-term goals. The short-term goals are less than 30 days approximately. That again contains same thing, the treatment up titration, rehabilitation program, NTP primary guided therapies, newer therapies, same thing, we already discussed it. Then there is a midterm. This contains the patients who have been sent to home, but even after sending home, they are not able to maintain their, what you can say, lifestyle just because of the early treatment withdrawals. Patients are non-compliant to a treatment. Many of the times, mitral valve structural heart diseases causing them to relapse again. In those patients, treatment such as MitraClip will help. Resynchronization therapies, again CRTP, CRTDs help in the same. Atrial fibrillation, I have already told you. EP study and ablation will help to cut down the incidences. And lastly, the LVADs. Same slide. This is something new. So this is a comprehensive geriatric assessment scale. This is a scale in those patients, particularly this is more common in the old age patients, in which we generally talk about the heart failure. But along with that, there are other things, such as they have cognition impairment, there is dysautonomia, there is denutrition or other comorbidities, or even depression. As we all know, most of the patients of heart failures, they are repeatedly hospitalized. They are chronic, on chronic treatment for long-standing duration, and in spite of having long-standing treatment or compliance to treatment, many a times there have been relapses. Those gives rise to a mental problems to arise. That contains depression, or even sometimes they have memory impairment as well. This is another thing. Most of the medications which we use for heart failure, they either contain diuretics or the other medications which include RAS system. And most of the patients of heart failure have cardiorenal syndrome associated with that. In those patients with the treatment, we face a problem that is hyperkalemia. So as soon as you get an hyperkalemia, the drugs, half of the drugs are absolute. That includes sacubitril valsartan, that includes ACEs, ARBs, even MRAs. So half of your drug portfolio has been out. So monitoring potassium level is also important. The opposite side is also true. Many of the patients who have presented with acute heart failure, we put them on diuretics such as Ditor infusion or something, and some of them land into an hypokalemia. And hypokalemia, if they have underlying coronary artery disease, they will face arrhythmias, or even many a times VF or VTs, I mean all, atrial as well as ventricular arrhythmia, that can be fatal. So monitoring of potassium levels is also a key role. Dehydration is another thing. As sir said, there are wet patients, there are dry patients. So sometimes volume, just because you have dehydrated patient too much, you are not monitoring the CVP or you are not monitoring the IVC. Because of that, pre-renal AKI is very common in those patients. If you are not, without monitoring the CVP, if you are continuously putting the patients on intravenous diuretics, because of the loss of volume, there is a hypotension. And to control that hypotension, we are treating it with NORAD. Noradrenaline, from my point of experience, many of the patients of chronic heart failure, we are trying to achieve the core BP, or you can say non-invasive BP, 200, 120, that are our goal. And noradrenaline is good for a short-term thing, touch. If you give it for a longer duration, it will cause intrarenal vasoconstriction, it causes, less like vasopressin, it causes gut vasoconstriction, it causes liver vasoconstriction, and that gives rise to an liver derangement, kidney function derangement, as well as gut ischemia. So we should be wiser in giving the inotropes and deciding what is the optimal BP for the patients. So as we have already discussed, this is the flow chart. That contains, if the patient is having ejection fraction less than 40 or more than 40. If the patient has ejection fraction less than 35 with a broader QRS complex with LBB with QRS more than 150, it is actually more than 140 as well. We can go for a CRTP or CRTD. With a less ejection fraction, ICD becomes a class 1 indication. And those who are refractory to all these treatment, they can be sent for LVAD or eventual heart transplant. Same thing. there are, okay, these are the clinical trials that contains CARE-HF and MEDIT-CRT, then MEDIT-I trial, SCD-EF trial, DEFINITE trial, co-op trial is for the MITRA clip, MITRA-FR trial, and for cardio-MIMS that we will discuss afterwards. There is a champion trial which have shown mortality benefit. This is the flow chart. CRT always helps to reduce the hospitalization as well as the mortality benefit. So this is a newer technique. Cardiac contractility modulation. This is a newer therapy in which the heart is being sent a non-excitatory signals. The signals are being put in the absolute refractory period. Basically, the signals have been put in that period in which it will not produce a contraction, but the studies have shown that because of this, there is overall increase in myocardial contractility and efficacy. The ejection fraction is improved. This is the device with a programmer and a battery. Then other neurohormonal modulation, there are multiple things. One is renal denervation, sympathetic stimulation, and baroreceptor thing. Baroreceptor activation is one bad therapy, we called it as. It causes sympathetic inhibition and increase in parasympathetic activity, basically what beta blocker causes in short. It reduces heart rate, it reduces remodeling, it increases vasodilatation, reduces the BP, and reduce in BP helps to reduce the rate of hospitalization. Then there is a vagal nerve stimulation, same thing. This is for mitral regurgitation. As I talked, if the mitral regurgitation EF is good, then patient ejection fraction is good, then we can straight away send the patient for mitral valve surgery if it is having underlying coronary artery disease as well. If those patients with EF is good, they have persistent symptoms, they can still go for this is a class 2B, one mitral valve surgery. Patients with very poor EF, the surgery outcomes are guarded, so edge-to-edge repair or a mitra clip is the best. This is mild, my mid-range ejection fraction patients. Again, we use diuretics, SGLT2, ARNIs, ARBs, similar, no change. Again, for preserved ejection fraction, the drug table is same. So this is so as we all know, amyloidosis. Amyloidosis is basically a storage disorder in which the transthyretin is deposited on myocardium, and that is causing repeated episodes of heart failure. So tafamidis is a newer drug that helps to reverse the disease, basically. Again, same. This is the last slide. So as already Ashish has shown this slide. So whenever there is onset of heart failure, the course is decided by the treatment initiation. So those patients who reach to the hospital in time, then that decides their course of illness will be going towards the positive side or negative side. Those who are unable to reach to the hospital in time, definitely they have grave prognosis. So our target is to detect the patients in their early stages, maximize the treatment, and those who need a structural interventions such as mitra clip or CRTPs or CRTDs, even electrophysiological studies and ablation, they should be segregated and sent to a cardiologist in time. Thank you.
Hello. Thank you very much. Elaborately you explained everything, Dr. Pranil, regarding the treatment of refractory heart failure. Causes or pathophysiology explained by Dr. Ashish. Because we already extended time, so in the constraint of time, I only ask one or two questions from the floor. And if there is no question, then we can call. One last question, only thing is that fourth pillar for the management of refractory heart failure, that is the SGLT2 inhibitors. In spite of that no diabetic, we can use that molecule for the refractory heart as a medical management.
Yeah, sir. Already, along with this BiPAP, I should have said there are other modalities such as ultrafiltration. So basically, all drugs whichever causes a volume reduction, SGLT2 mechanism of action is similar. It reduces glucose and glucose carry, or with the sodium it reduces glucose.
Nitriuresis.
Nitriuresis. Yeah. So nitriuresis, glucouresis, and water, free water along with that. So the mechanism is remaining same. So and those patients, particularly as I have told, diabetes is most of the patients of heart failure. They are under stress. So stress hormone levels are, whenever is high, their glucose is by default is rises. Just like in AMI, patients who have acute myocardial infarction, most of the non-diabetic patients will have rise in blood sugar level.
Even this decrease the intraglomeralular filtration.
Glomerular filtration, yes,
yeah,
sir,
that
yes,
is
sir.
important.
Yes, correct.
Okay. Any questions from the floor? Okay, thank you.
I will request to felicitate. So see, we are nearing the end of the day, so we have only two small things remaining. One is details about very SIGWAT. On the request of our team, we'll be speaking on very SIGWAT, a short 5-10 minutes talk, and then Dr. Ravish is going to ask a quiz. Physicians should be interested in that quiz. 20 MCQ ECGs, 10 ECGs is going to present. So in the next 15 minutes, I think we should wrap up the sessions. And we will felicitate our respected speakers, Dr. Ashish, Dr. Pranil, after the very SIGWAT discussion. So let's finish the very. Have you loaded it, ma'am? Sure. So today we had a very interesting day. Yeah, is it loaded, ma'am?
Where is your tab? This one gave you, na? That you want to present. See, no? तो मेरे पास नहीं है. उसको भेज दो, तब तक नहीं कर. So now the next speaker is Dr. Rajiv Sharma sir himself. I would like to request, requesting Dr. Ashok Kamble sir to come and chair the session. Sir is a very senior physician practicing at Dahanu since 1990, and he will introduce Dr. Rajiv Sharma sir.
We had a quite extensive discussion on heart failure
Dr.
today.
Ravish is there.
I'll introduce Dr. Rajiv Sharma to you. Dr. Rajiv Sharma is MD DM Cardiology from KM Hospital, Mumbai, and is a member of SCC, SCAI, AHA, and ESC. He was a college topper in final MBBS, a university topper, gold medalist in DM course, and also won the Dr. PYN Award in cardiology at KM Hospital. He specializes in clinical and interventional cardiology alike. He has done national as well as international publications. He has been actively involved in research and in teaching programs at university levels. He has done more than 10,000 cardiac interventions. He is the cath lab director and partner at Phoenix Heart Care Super Speciality Hospital at IC Colony, Borivali West. He is the director of Avigna Heart Care Clinics. I request Dr. Rajiv to take over, please.
Yeah, so we had a very interesting heart failure day today. We had topics on acute heart failure by Dr. Venkat Goyal sir. And as we know from the acute heart failure stage, the patient, so we have risk factors for heart failure, which is stage A. And from the risk factors, the patient starts getting signs and symptoms of heart failure and land up with us with acute heart failures. After the acute heart failure, there is a stage of worsening heart failure. Worsening heart failure is when a patient is stable. A heart failure patient is stable, but he gets those episodes of heart failure again and again, and they keep coming back. And that is called as recurrent heart failure or worsening heart failure, and then we have advanced heart failure. Advanced heart failure has 3 stages. So they were discussed by Dr. Ashish Mishra. My presentation is getting loaded. So what I want to talk about is very significant. So we know that chronic heart failure has got 4 pillars of heart failure therapy, which Dr. Pranil has already discussed. The 4 pillars of heart failure therapy are A standing for ACE inhibitor, ARB, or ARNI. Then the second is B stands for beta blocker, which is a very important foundational pillar for heart failure long-term management. And the third drug is SGLT2 inhibitor, which is either dapagliflozin or empagliflozin. And the fourth drug is a mineralocorticoid receptor antagonist, which is either spironolactone or eplerenone. There is a 5th pillar for heart failure therapy, which people are proposing it to be vericiguat. Vericiguat is a special molecule because it's a soluble guanylyl cyclase stimulator. So this vericiguat works not only on SGC levels directly, it also indirectly increases the nitric oxide levels, and that is how cyclic GMP stimulation helps in improving the signs and symptoms of heart failure. So when do we add vericiguat? Vericiguat is added in worsening heart failure. As I already told you, what is worsening heart failure? A stable patient of heart failure who is getting to your hospital again with breathing difficulty. So either you have to give them injectable diuretics in your clinic, or you say ki Lasix 40 घेऊन घरी जा, or those patients who have a need to step up the foundational therapy. So those are the patients of worsening where vericiguat has its role. And I don't think my presentation is getting uploaded. I'll request the presentation to be seen later, and we can ask Dr. Ravish to conclude with the quiz. Is Dr. Ravish there? Ravish, Dr. Ravish. Yeah, so this is the presentation, it is already come. I'll just go through it a little fast. Yeah, so how do we change the trajectory in worsening heart failure? As we know, heart failure is a progressive disease, we have already discussed. Stage A is the heart failure risk factors, those hypertension, diabetics, dyslipidemic, sedentary, obese guys. Then there is a, in the few years, the patient progresses to signs and symptoms of heart failure. And as the time progresses, these patients have a reduction in the quality of life, and then they get those episodes. So those spikes are worsening heart failure episodes. Every worsening heart failure takes the patient closer to death. So this is a stage which is very important. So we discussed advanced heart failure, but I am talking about a stage before that where the patient is getting worsening. So can we change the trajectory? Can we help the patient survive a little longer? What is the definition is, it's a deterioration of heart failure signs and symptoms despite stable therapy, established patient of heart failure, and requires urgent escalation of therapy. Every worsening heart failure brings the patient closer to death, and repeat hospitalizations are very, very high. In the first month, rehospitalization is 56%, and almost 70% of these guys get hospitalized within 2 years again. So the definition includes worsening symptoms but excludes new heart failure patients, and also patients who have a trigger for their heart failure worsening. For example, pneumonia. A patient who gets pneumonia and his heart failure worsens is not worsening heart failure. Okay? Or if a patient has stopped medicines, ki aushadha band karun ala, that is also not worsening heart failure. Worsening heart failure is a patient whose pathology, whose heart failure is worsening. Okay, his underlying structural changes in the myocytes and myocardial relaxation are the reasons for that. So this is a vulnerable phase where patient is getting vulnerable, worsening heart failure episodes, and that is where vericiguat has its role. So these are the two types of patients who come to us. Ravi is a 72-year-old guy who was diagnosed with HEF-REF, has an NT-proBNP of 2200 despite being on medical therapy. He comes to us with worsening breathing difficulty in the OPD. So what do? We stabilize the patient on IV diuretics, we admit him for a couple of days, we decongest him, and before discharging, what else can we do? We can escalate the dose of the foundational 4 pillars, or we can introduce vericiguat. So introducing vericiguat, if the BP is borderline, introducing vericiguat is a very sensible decision because it does not worsen the BP, it does not worsen the renal function, and it does not cause significant symptomatic hypotension. So vericiguat is a very good add-on pillar rather than increasing the dose of ARNI from 50 to 100. Other type of patient we get is Sharda, who is a 59-year-old lady with a 2000 BNP, a CKD patient. Now CKD also is very important because ARNI, SGLT2 inhibitors are EGFR dependent drugs. Also CKD patients have a high incidence of hyperkalemia. So we can't use mineralocorticoid receptor antagonist to their full effect many a times. So these are the patients which will also benefit from introducing vericiguat. So vericiguat works by the cyclic GMP stimulation by nitric oxide dependent and nitric oxide independent pathway as well, and helps in reducing inflammatory process, fibrosis and hypertension, hypertrophy in the heart, reduces inflammation in the blood vessel level and increases vasodilatation, reduces renal fibrosis and increases the renal blood flow. So independently as well as via cyclic GMP stimulation via nitric oxide pathway it can work, and these are the patients who will benefit from adding of vericiguat. So in short, we can introduce vericiguat when a patient experiences a worsening heart failure episode, and it may be considered as one of the add-on pillars to the background 4 pillars. Thank you so much, and I'll request Dr. Avish to take the quiz.
मैंने भेजे हैं स्लाइड्स
स्लाइड्स are loaded. किसको भेजा है? देशपांडे सर के पास है?
विनीत दंडोती सर को भेजूं? नहीं, मुझे लगा ये
संतोष है? तेरा ये है ना, इस पे जाएगा डायरेक्ट
इसमें मेल है इधर.
हाँ उधर इसको दे देंगे व्हाट्सएप.
So, good afternoon, everybody. Sorry for the delay, whatever has been caused. I will try to finish my slides in 5 to 10 minutes only. I am Dr. Ravish Raval. Hello, I am Dr. Ravish Raval. I am consultant cardiologist at multiple hospitals across Vasai. I visit ISS Hospital, Cardinal Hospital and Riddhi Vinayak Hospital. I am also attached at Karna Hospital, Borivali. Hoga? Slide done. वो क्या? Slides. Difficult होता है. Very 10 or 12 small few ECGs, moderate intensity difficulty, only 1 or 2 common ECGs, otherwise more related to arrhythmias rather than heart failure or this one coronary artery disease, because that have been very common. Okay. ये नहीं लोड किया अभी कहाँ है क्या करूँ So first question, histories of 26-year-old primary gravida, post normal delivery, had history of resuscitated cardiac arrest. 2D echo as we do now regularly with the advice of VVMC prior to delivery was normal. But ECG showing what? Can you guess? The QT is prolonged. So Holter showed polymorphic VT, and so what is the treatment? First treatment is beta blockers. If they don't respond to beta blockers, may require ICD if recurrent events. Some long QT syndromes are 3 types, 1, 2, 3. The second one is most pregnancy related. Then second one clinical is history of syncope, has sudden agonal respirations in night. This is a very typical clinical history, but still gets survived. So ECG is below, and family history of sudden cardiac death. V1, V2, V3. Yes, Brugada syndrome. It's a rare congenital disorder. ECG anomaly is sometimes precipitated by fever and some drugs. Mimics anterior wall MI, but you should have to clear, because my one patient had Brugada pattern, but he had ACS anterior wall MI. So you have to clear anterior wall MI because that is a treatable and condition with immediate death chances. So next, syncope may be there, which is not related to fever and may require ICD according to risk. This is a 25-year-old male having history of palpitations since 1 year, again palpitations since 1 hour, and BP is 70/50. This is the ECG. Yes, atrial fibrillation, but it is broad. So it is atrial fibrillation with a WP. There is an accessory pathway which is causing the broad atrial fibrillation. Normally, atrial fibrillation can occur with LBBB or RBBB aberrancy. That is not a problem, but that will not be so fast because of the bundle branch aberrancy. It will be 120, 130, 150. This rate is nearly going to 200 plus, and this is a very AFib down the accessory pathway or WBW syndrome, and this will cause sudden degeneration into VT VFib. Also remember, any SVT which has hemodynamic deterioration 70/50 BP or any hypotension, any heart failure or chest pain, please don't give any drugs. Cardiovert, that is the worst. DC cardiovert, synchronized DC cardioversion is the treatment for any SVT. So when there is hemodynamic compromise, if you have good BP 160 or whatever, you can find good BP, then you can try for adenosine and all those drugs one by one, and you have a typical SVT, then you can try. So broad fast charted, this is what was the baseline ECG. It had showing P pro delta. So what for a WPW syndrome, also remember the syndrome is only defined when you have a palpitation or an diagnosed tachycardia. Till then it is only a pattern, because many patients, 90% don't have any symptoms or any palpitations throughout their life despite the pattern, because the pathway is very slow. Same patient after getting beta blocker, this patient was treated with beta blockers before the ablation was planned. This time, because the pathway differential, one pathway blocked and one did not block, there was orthotomic tachycardia. This is pure SVT, what you call it. This is AV nodal dependent, it can be AV nodal dependent, it can be AV-RT also. This is AV, this was AV-RT because accessory pathway is there. No, 90% is AV-RT. Very difficult to differentiate except in an EP study, in a cath lab with an EP study. But the treatment is same. For this type of tachycardia, if there is no hemodynamic deterioration, it will be adenosine for termination, or even beta blocker on Dilzem on second or third choices. So adenosine has to be given a push, central IV line, and you have to flush immediately. Otherwise, the adenosine will not work. Also, there is many times seen a pause after adenosine because it induces heart block. So unless it is a very prolonged pause, there is no need to pace usually, and you can keep atropine standby. So this is a 25-year. I think the slide is gotten hidden. 25-year-old male. This is broad tachycardia. This is the patient has no history of heart disease and totally normal echo. This is what you call structurally normal heart VT, RVOT VT. So this is type, the 2-3 AVF are positive, so they're coming from top type. So there is a complete degradation, but this is a broad complex tachycardia. Unless you are sure it is previously a pathway, you have to better cardiovert the patient. Now, though if no hemodynamic compromise, beta blockers, you know the patient is coming repeatedly, then you can give. You are diagnosed patient. And the treatment is DC cardioversion, and long-term treatment is ablation again. So this you all know. Anybody? Cardiologists have an idea always to locate. No location. Anterior MI is enough. Always remember, MI will have reciprocal changes most of the time. Your ST elevation in 2-3, V1, V2, V3 has depression in 2-3 AVF. So usually there are reciprocal, that is actually a sinacon. No changes in V1, V2, V3, there will be mostly early repolarization syndrome, what we call. So this is having what is this? Yes, so it's inferior wall, sorry, there are some changes in the anterior wall, V1, V2. So this 84-year-old male, what is this? So if yes, this is 2:1, Mobitz type 2 block, whatever called, higher degree AV block. If you don't see the P wave sometimes, it happens many times that it goes into the T, but the heart rate is low. If the heart rate is 50 without sinus bradycardia, you cannot see that. Most likely there is a 2:1 heart block. But here you can, some places and lead 3 like, there is a differentiation of a P wave separate from a T wave. So you can make it 2:1 heart block. Now what is this? Complete heart block. And what is this then? Cardiologists don't answer. No? So it is progressing PR. So what is important is the longest PR has to be taken in consideration. The longest PR is more than 200 milliseconds. So it is a heart block. And also I wanted to very clear, there are 2 theories in this one. I don't consider this is conduction of this. I always consider this is condition of this. That is the prolonged duration, because it is impossible for it to conduct slow in such a, when it progresses from first degree heart block to second degree heart block. So your PR should still prolong. You cannot have a P. So that is actually a conducting of the previous P. That is the delay, that is the problem. So thank you. Short slides for ECG quiz.
अनामिका मॅडम जे दिले ना पहिला स्लाइड
40 years in my practice, this is the first time I have received such a concentrated amount of cardiology. I think we should thank all those who are responsible. First of all, thank to our esteemed faculty of speakers, starting with Dr. Rajiv Bhagwat, Dr. Venkat Goyal, Dr. Harminder Singh, Dr. Rajeshwar Joshi, Dr. Ashish Mishra, Dr. Pranil Gangode, and with Dr. Rajiv Anand. And a special thanks to Dr. Venkat Goyal, as someone said he would leave, but for making this beautiful hall available for us. Thanks to our President Secretary for thinking of it, this idea of a concentrated cardiology conclave, and thanks for Dr. Rajiv Sharma to take it forward. Thank you to all the chairpersons. Thank you, Dr. Ashok Kamble, for giving that wonderful welcome speech in the beginning. All the chairpersons, Dr. Prashil Patil, Dr. Suresh Sonavane, Dr. Rakesh Patil, Dr. Bhuraj Sane, Dr. J.N. Yadav, and again Dr. Kamble. And a big thank you for all of the doctors who attended today, and special thank you for waiting and listening to this vote of thanks. And thank you for the excellent audio-visual, and I'm sure thank you to the caterer who will have a lovely lunch. Thank you for the wonderful breakfast. All the sponsors also, please do visit the stalls. Who are the main sponsor, I think they are still waiting. Thank you, sir, thank you because of this. Torrent Pharma. Thank you. President Rajo. President Secretary, yes. And if inadvertently, if I missed out anyone who have been responsible for today's function, a big thank you to everyone.